another 5-10 minutes. Till then, you can look at the screen or wait in anticipation. So there are a few doctors who say they're just on their way, so we'll just wait another 5 minutes. Thank you.
Aster MIMS Hospital, Calicut has gone into the largest healthcare provider in South India, offering comprehensive quaternary healthcare services for more than 2.5 decades.
Our hospital began its journey 25 years ago. Back then, we were the first in the region to promote emergency primary angioplasty, a decision that went on to save thousands of lives.
In the Department of Emergency Medicine, every second counts and every team member knows it. We have implemented streamlined chest pain protocols and have worked tirelessly as a team to achieve an excellent door-to-balloon time comparable to the best in the world.
Our mission was clear back then, to offer world-class protocol-driven cardiac
You
care.
guys must be wondering what this
From that
video
day
is
till
going
today,
on.
We're extremely
Continuously.
proud.
So
To say that
this
we have
year
been
we
instrumental
got
in revolutionizing
the
cardiac
American
care
Heart
in this
Association's
part of southern
accreditation
India.
for
From
being
complex
the first
coronary angioplasty
hospital
complex
in
coronary
India
care for being the first hospital in India to get the AHA accreditation for a comprehensive chest pain center, for to being a STEMI point of care first hospital to be accredited by the American Heart Association. So this video is basically to show that particular thing. So yeah, I think we'll cardiac care in this part of the region. We've grown with our community, treating not just heart disease, but earning the trust of generations across patients in Kerala and southern India. The American Heart Association certification for being the first in India comprehensive chest pain center was really a proud moment for all of us.
This accreditation stands as a testament to the high standard of quality healthcare services that we provide, especially in case management. We are proud and honored to become the first hospital receiving such a prestigious recognition.
This certification today is a tribute to our legacy for quality cardiac care for the last 2.5 decades, and it's a reaffirmation of our unwavering commitment to timely, evidence-based cardiac care. At Aster MIMS Calicut, we are proud to set a benchmark not just for us, but other hospitals across the state of Kerala and across India. It's a call to elevate the standard of acute cardiac care for the whole nation.
This journey of accreditation was not just about receiving a certificate. It was about building the strength of the hospital, the infrastructure.
A very good morning to all respected faculty members, consultants, specialists, residents, and delegates. On behalf of the Department of Cardiology, Aster MIMS Calicut, we warmly welcome you to CME Back to Basics Season 8.
Yes, Back to Basics is back again. One of our department's most awaited academic events and a tradition where we revisit the fundamentals that shape modern cardiology, but in the most practical, simple, and high-yield way possible.
And as always, Back to Basics continues under the leadership of the very team that has shaped this program year after year. Our interventional cardiology faculty, led by Dr. Salman Salauddin Sir, Senior Consultant and HOD, together with Dr. Sudeep Koshi-Kurian, Dr. Bijoy K, and Dr. Sandeep Mohanan, our Senior Consultants in Interventional Cardiology, along with Dr. Mohammad Feroz and Dr. Anwar K, our Senior Specialist Cardiologists.
And supporting today's academic execution are our course co-directors, Dr. Varshit, Senior Cardiology Specialist, Dr. Mangala Shashidharan, Cardiology Specialist, Dr. Ahmed Sadiq, DNB Resident, Dr. Chandini PS, DNB Resident, and Dr. Jinshi K, Senior Resident. They are the academic backbone of Back to Basics, and the reason this program has gone into such a consistent high-value learning platform every year.
Before we begin, a quick note on today's format. Each session is scheduled for 30 minutes with 15 minutes of presentation, followed by 15 minutes of moderated discussion. And the interaction today will be fully digital based, making it easier for everyone to participate throughout the sessions.
This will help us keep the flow smooth and ensure every topic gets the right amount of interaction. And with that, to officially set the tone for today's academic sessions, we would now like to invite our host and organizing secretary for Back to Basics Season 8, Dr. Salman Salahuddin, Senior Consultant in HOD Interventional Cardiology, who will also be guiding and moderating our sessions throughout the day alongside our other faculty.
Thank you. Thank you. Good morning, everyone, doctors, delegates, my staff members. Very hearty welcome to all of you back to Basics Season 8. It's a very warm and pleasurable moment for me today. A proud moment for all of us in the Department of Cardiology, hosting the 8th season of this yearly annual cardiology event hosted by our department. A very great to see a lot of familiar faces and a lot of unfamiliar faces. Not sure how many of you had attended us in previous sessions. Anyway, for those who are new to Back to Basics, I'll give a quick wrap-up of what our Mrs. Salim just mentioned. So we've got basic clinical topics lined up for you today, which are day-to-day relevant topics in clinical cardiology. So we've got a topic on peripheral artery disease by Dr. Bijoy. We've got one on cardiac CT. A lot of people are doing cardiac CT these days, how to interpret these things. We've got a session on sudden cardiac death, newer advances, and in ECG, how to recognize mimics of myocardial infarction. So as our beautiful hosts and MCs just mentioned, we want it to be as interactive as possible. So we've designed it in such a way that after each talk, around 15 minutes, we're going to have 15 minutes of discussion. So I will, after the first talk, introduce to you our digital platform, menti.com. It might be familiar to most of you who were there in the previous sessions. For those who are not, I will still introduce it to you after the first talk. In such a way, we can have questions live to discuss with the faculty, expert faculty who are here today, and make it as academically interesting and extravagant as possible. So once again, welcoming you all to Back to Basics Season 8, and let's kick off today's academic extravaganza. Over to you, Salim.
Thank you, sir. To start off, let's think of a scenario we have all heard. Doctor, the ulcer on my big toe is not healing and it's turning black. A simple line, but one that opens up an entire pathway of clinical decisions.
To break that down for us, we invite Dr. Bijoy sir to speak on decoding diagnostic modalities in peripheral arterial disease for the first session of the day. We welcome you, sir.
Good morning, all. Welcome to Back to Basics 7th, 8th session. I'm very happy to present the very basic topic, diagnostic modalities in peripheral arterial disease. The spectrum of peripheral arterial disease extends from asymptomatic peripheral arterial disease, where there may be some functional deficit, and it extends through chronic symptomatic peripheral arterial disease patient, where the patient can have claudication, non-activity limiting or activity limiting claudication. And the advanced stages, chronic limb-threatening ischemia, previously called as critical limb ischemia, can happen with ulcer and gangrene formation. If the duration is more than 2 weeks, we call it chronic limb-threatening ischemia. And acute limb ischemia occurs if the duration is subacute within 2 weeks. We all see this type of presentation, a diabetic 60-year-old male presenting with discoloration of, here you can see that fourth toe is discolored and the big toe also is discolored. He comes into the category of chronic limb-threatening ischemia because the duration is more than 2 weeks. There is ulceration, gangrene, and this is potentially limb-threatening. There is a risk of amputation. This is a tip of an iceberg of severe systemic atherosclerosis. It is not a matter of a non-healing ulcer. He has chances of coronary artery disease and stroke, which contributes to the mortality. Once you see such a patient with non-healing ulcer, his 5-year mortality is 50 to 60%. Within 5 years, 50% of the patients will die because of coronary disease or stroke. And it increases the cardiovascular disease death by 6 times. And the amputation risk is around 20 to 30% within 1 year. A non-healing ulcer has so much of implications. And we'll go to the investigations. We all know about ankle brachial index. Ankle brachial index is usually measured using Doppler. The leg blood pressure is measured at either dorsalis pedis artery or posterior tibial artery. And the brachial artery pressure is also measured. Ankle brachial index is the ratio of ankle pressure divided by brachial artery pressure. Normally, lower limb arterial pressure is much more than upper limb arterial pressure, we know, because of the hemodynamic matters and the reflected waves from the periphery. Normal ankle brachial index is 1 to 1.4. Anything more than 1.4 is abnormal because of non-compressible artery. When the arteries are not compressed, it goes above 1.4. And the borderline values are 0.9 to 1. Any value less than 0.9 implicates significant occlusive arterial disease. Ankle brachial index it predicts limb risk as well as cardiovascular risk. When the ankle brachial index is 0.7 to 0.9, it implicates mild peripheral arterial disease with claudication. If it is 0.4 to 0.69, it implicates moderate peripheral arterial disease with significant claudication. And when it drops less than 0.4, it is indicative of severe peripheral arterial disease with critical limb ischemia. And the patient will be having rest pain, which makes the patient sit the entire night with the lower limb hanging, and ulceration and gangrene can occur. ABI is a cardiovascular risk marker also. The lower the ABI, the greater risk of cardiovascular mortality. In any patient with low ABI, less than 0.9, there is a 2 to 3 times increased risk of acute myocardial infarction, and the stroke increases by 2 times. And also, there is a 3 to 6 times increase in the risk of cardiovascular mortality. So, it is not a matter of non-healing ulcer, it is a reflection of systemic atherosclerosis. And the ankle brachial index is unreliable in certain group of patients. When there is medial arterial calcifications, it becomes unreliable, as in diabetes mellitus, chronic kidney disease, and elderly patients. Then we'll have to use toe brachial index. Toe brachial index, toe blood pressure, systolic blood pressure is indexed to the brachial pressure. Toe pressure is measured by a small cuff, 2 to 2.5. You can see that small cuff there, 2 to 2.5 centimeter in size. And Doppler or photoplethysmography is used to assess the digital systolic pressure. Normally, toe pressure is less than that of ankle pressure because there is no reflected wave and the artery is very small in caliber, maybe 1 to 2 millimeter. And these toe arteries are less affected by calcification and it's a better predictor of wound healing. And it is useful in small vessel peripheral arterial disease. The TBI interpretation is more than 0.7 it is normal, 0.64 to 0.7 it is borderline, 0.4 to 0.64 predicts significant peripheral arterial disease, and less than 0.2 it is suggestive of severe ischemia, ulceration and gangrene, critical limb ischemia. And the toe pressure less than 30 indicate poor wound healing, and less than 20 the amputation risk will be very high. Another technique is segmental limb pressures. This is a modification of ankle brachial index. You can see BPF cuff attached to the thigh, leg and ankle. And you will be recording the blood pressure in the brachial artery, thigh, upper thigh, lower thigh, leg and ankle. And you can see it on the diagram. On the left side, on the right side, you can see that blood pressure is increasing as you go down. The femoral pressure is more than 170, 158, almost remaining same. And the ankle brachial index is 1 actually, on the right side. On the left side, you can see that there is a significant pressure difference in mid-thigh. Mid-thigh 140, second value is 140 and the third one is 116. Any pressure difference more than 20 millimeter is significant, and that denotes here it denotes obstruction in the superficial femoral artery. Also, pulse volume recording also is available along with this segmental pressure monitor. You can see the pulse volume tracing on the right side. You can see a sharp upstroke, a pointed peak, steep downslope, and a dichrotic notch in all the recordings on the right side, including ankle. On the left side, you can see that there is no dichrotic notch in any of the tracings, and also the peak systolic volume is less, and there is a rounded contour. And when it reaches the ankle, you can see that it's a sine wave pattern without dichrotic notch, and the amplitude is very less. It indicates severe peripheral arterial disease. And you can see that ankle brachial index is somewhere around 6.64. And exercise testing, it is used to assess the functional limitation, response to treatment, as well as latent peripheral arterial disease where the ankle brachial index is normal at rest. And it can be done with treadmill test or with 6-minute walk test. Whenever there is a 20% reduction in ankle brachial index after exercise, it is suggestive of latent peripheral arterial disease, which is not detectable in resting AB index. And one of the initial screening tests is Duplay ultrasound. It employs different ultrasound modalities. One is B mode imaging, which is bright imaging mode, and it can detect the vessel plaque, thrombus, vessel caliber, and when you add color Doppler, it can detect the occlusion and flow direction. The third component is spectral Doppler, which will record the peak systolic velocity and waveforms. We may have seen so many reports of arterial Doppler saying that triphasic, biphasic, monophasic and all. What is triphasic? Basically, a Doppler pattern of normal blood flow has a systolic forward wave, early diastolic reversal, and late diastolic forward flow. That is the triphasic flow, which is shown in the first picture. And it is normal. There is no obstruction. The vessel compliance is normal. And in the second picture, you can see that there is a systolic forward flow, there is a diastolic flow reversal, but there is no late diastolic forward flow. That is biphasic. That can happen with mild disease or with aging. And the third is monophasic flow, where there is no diastolic flow reversal, and it happens with severe stenosis or occlusion. And the last, in the D, you can see Parvus-Stardust pattern. That is a delayed upstroke, which indicate a proximal severe stenosis. And the grading of stenosis is based on the peak systolic velocity ratio, stenotic peak systolic velocity divided by proximal peak systolic velocity. 1 to 1.5 is the normal. When there is a flow acceleration, when it is 2, ratio is 2, there is a 50% stenosis. When the ratio is more than 2.5, 50 to 75% stenosis. And when it is more than 3.5, more than 75% stenosis. No flow and collaterals means there is a total occlusion. Duplay Doppler is non-invasive, radiation-free. There is no contrast required, and the study can be repeated. And it provides an anatomical as well as hemodynamic assessment. Okay, but it is operator-dependent and has problems with calcification, obesity, and edema. And it is difficult to delineate distal vessels like pedal arch and tibial arteries. Coming to computed tomographic angiography, you can see a beautiful picture with 3D reconstruction on the left side showing occluded infrarenal abdominal aorta with distal reformation at the common femoral artery level. A CT has a high spatial resolution and it is excellent for aortoiliac, femoropopliteal and below the knee arteries. There is a rapid acquisition and it is widely available, and it is best to detect calcification. And also it provides a 3D reconstruction images like this for planning revascularization. For this patient, if you are planning aorta bifemoral surgery, you can assess the proximal zone and distal zone where to anastomose and all. The limitations of CT angiogram are, it needs contrast and calcification may obscure the lumen. There is a risk of radiation exposure and contrast exposure, which can be harmful in CKD patients and less accurate in below the knee vessels. An MR angiography gives similar result. It can find out the stenosis, occlusion, aneurysm and dissection. And also it can assess the inflow and outflow vessels and assess muscle perfusion also with MR angiography. There is no ionizing radiation, there is no contrast, and gadolinium is better than iodinized contrast in the presence of normal renal function. It is excellent for aortoiliac and femoropopliteal vessels, and it allows the plaque characterization also. And the conventional angiogram, this is the gold standard for planning treatment. You can see two images. One image is a conventional angiogram that shows superficial femoral artery, popliteal artery, and the bifurcation. And the second image is digitally subtracted image, whereby background structures are removed, which allows a good visualization of the vessels. And this is excellent for smaller vessels and below the knee vessels. There is a real-time imaging which can be done during intervention. And the lower contrast actually is needed for digital subtraction angiography if you selectively inject the arteries. And tibial, peroneal arteries and small vessels can be delineated very beautifully with the digital subtraction angiogram, and multiple projections can be taken to assess the stenosis. And another technique is carbon dioxide angiogram. This is run routinely in our center, but not done much in other centers, I think. This uses the carbon dioxide gas as a negative contrast agent. And imaging is done without any iodinated contrast. And it is useful, very useful with CKD, where the contrast can be harmful, in iodine allergy patient, and diabetic food where you need so much of contrast. And this is performed under digital subtraction angiography. And you can see the images. The white one is that of carbon dioxide angiogram. It's almost similar to the contrast angiogram with good opacification of the superficial femoral, popliteal, and upper tibial and peroneal arteries. CO2 angiogram has advantage of no nephrotoxicity, no allergy to contrast. It has a low viscosity and it passes through the stenotic vessels very rapidly. It is cost effective and available. But there is a poor visualization of the pedal arch. Distal vessels are not visualized with carbon dioxide angiogram. And it should not be used above the diaphragm, because accidentally if it goes to cerebral circulation, it can have stroke. And also it is not suitable for coronary angiogram. Just few words about treatment in chronic limb ischemia. The aim is for revascularization is to establish pulsatile straight line flow, and less of blood flow is required to maintain tissue integrity than to relieve claudication. And the purpose of revascularization in critical limb ischemia or chronic limb ischemia is amputation-free survival and not for long-term graft patency. You can see the examples. You can see the aortoiliac disease. On the right panel, you can see the right external iliac is totally occluded, and left external iliac ostium has got 70% stenosis. The second panel shows aortoiliac reconstruction, and the images of aortoiliac, there is no stenosis, blood flow is good. And on the contrary, if you are sending the patient for bypass surgery, previously surgeons used aortobifemoral surgery for this type of aortoiliac obstruction. The operative mortality of aortobifemoral bypass is 5 to 8%, compared to less than 0.1% operative mortality for aortoiliac reconstruction. And this is a patient with critical limb ischemia having non-healing ulcer, having a critical disease in the femoral artery. First panel shows more than 90% diffuse disease of mid-third of femoral artery, and the second panel shows post-angioplasty results. And this is infrapopliteal intervention. This is reserved for limb-threatening ischemia only. You can see that infrapopliteal vessels are poorly visualized in the first image. After balloon dilatation, after PTA, both anterior tibial and posterior tibial arteries are well seen. This is a pedal reconstruction. You can see that plantar arch is poorly visualized in the first images. And after intervention, you can see that entire plantar arch with good branches going to the heels. This patient had a heel ulcer which improved after pedal reconstruction. And coming to the modern devices, most of the lesions sometimes may be calcific. There is intravascular lithotripsy, which is similar to that used in coronary arteries. It uses the sonic waves to fracture the calcium. For heavily calcified SFA, popliteal artery and below the knee vessels, intravascular lithotripsy is useful before stenting and before balloon angioplasty. And rotational, orbital or laser atherectomy can also be used just like coronary arteries. And it is used for debulking the lesions and to put either to use a drug-coated balloon or stent. And the drug-coated balloon with the paclitaxel is used in peripheral arterial disease also, just like coronary artery disease, and it reduces the restenosis risk, and it can be used for instant restenosis of peripheral stents. And the take-home message, it is not a matter of non-healing ulcer alone. PAD, peripheral artery disease, is a strong marker of systemic cardiovascular risk. Early diagnosis improves the outcomes with non-invasive angiograms and invasive angiogram. And revascularization and multidisciplinary care reduces the risk of amputation and improves limb salvage. Thank you.
Thank you for that insightful talk, sir. Now we call upon Dr. Mohammad Firoz to moderate this session.
Thank you, Dr. Joy sir, for that excellent overview of the peripheral artery disease.
How was it? Yeah, so great talk there, a lot of learning. So just as I mentioned, we'll get into the digital platform which I had mentioned earlier. So all of you have been given Wi-Fi codes in case you want Wi-Fi, or you can everybody can take out their mobile phones, please. Yes, this is the one place where we encourage use of mobile phones. Yeah, so right, so and if you want, you can use the hospital Wi-Fi which is there in your folder. You can just click on the QR code within the folder that gives you high-powered Wi-Fi of the hospital. That's a single click, or you can connect to your own networks, right? And after that, you all of you go to your whichever web browser and go to menti.com, right? Which you can see on the screen. Please type in menti.com, menti.com, right? And then you'll be asked to enter a code. The code is on the screen. You can either click on the QR code or go to menti.com and enter the code on the screen. We've got screens on the sides also for those who cannot see, on the left flank and the right flank. Right. So yes, I can see that all of us are very tech savvy and all of us are getting online. We've got more than 50 plus online. So again, for the last time, menti.com, the code 35345737. This will integrate all of us on the same platform, right? Okay, fantastic. For those, we are also live streaming on YouTube for our colleagues online. A big hi to you guys from wherever you're watching. And you can go into menti.com 35345737. So we got around 90 plus guys online. Okay, so I think that's a good number. So let's see how to go. So hello everyone, show us some love. Probably a thumbs up to understand everybody's online. Okay, Dr. Firoz, we're getting a lot of love there, right? Okay, that's nice, that's nice. Nice on a Sunday morning. Okay, so we'll have an important quiz question which is very relevant at this point of time to ask this very important clinically relevant question. So let's see how the poll is going on. And so we have a correct answer also for that, you know. So there's very truthful guys who are very much hungry. For those who are hungry, currently there is no option. And that option is opening up only after 2 more talks. Okay, so we've got the pulse of the audience here today. Right, so just to understand, yeah, so we're going to be digitally interacting in this particular platform. So all of you can just type in some word to understand how you're feeling right now. Okay, it can be anything. And you can say something bad about Dr. Firoz or something good, whatever. Right. So a lot of positive vibes coming up on Sunday morning, Dr. Bijoy, after your peripheral artery talk. Yes. Right. So that's great. That's great. So I think all of us are on the same platform here. This is how we're going to be interacting. I know most of us don't like to open their mouths, so all of us are very familiar with your phones. So here we go. So I think that's enough. Everybody's excited and hungry and happy, and let's proceed. Dr. Firoz, let's take the stage. Yeah.
So the CT angiogram is best for evaluating the plantar arch, aortic iliac occlusions, infrapopliteal disease, or femoral arteries.
So I think Dr. Bijoy mentioned a lot of investigations when you want to investigate a lower limb disease, and so he mentioned about ultrasound, duplex, a lot of things, the ABI. So Dr. Bijoy, please comment.
The right answer is aortoiliac occlusions.
Yes.
In nuclear ultrasound, it is not visible because of the obesity and
Okay.
abdominal areas. And also for conventional angiogram, also to plan surgical decision, it is better to do a CT angiogram, and it detects a calcification much better.
But does it mean that CT cannot see the infrapopliteal? Is it that? So what should the audience understand from that?
If there is excessive calcium, it will cause calcium artifacts, and it will not be visible. The lumen will not be visible.
Right. So, what for the physician when in this particular sitting, right, Dr. Firoz? So we have an aortoiliac. When should they suspect an aortoiliac occlusion?
Whenever the patient has butter coagulation or features of Leriche syndrome, you have to do a CT abdominal aortogram to see the aortoiliac disease.
So, and much more important, I would think, is the lost art of checking a femoral pulse. Yes. So
Only after checking the femoral pulse.
yes. So I would suggest, I mean, whenever in our clinical practice we have a patient with low limb claudication, we routinely follow. I mean, all of us should do it. If you have the femoral pulse, I think it would be something lower down, and if you don't have a femoral pulse, it's probably something aortoiliac. And in an aortic iliac, I think a CT would be a good way to do it. Why? Because it can be iliac, aorta. We have a lot of cases where the aorta is just totally occluded. And in such cases, the duplex sound, the ultrasound are not going to pick up aortic disease, and you may falsely underestimate the level of severity. So I think that's a valid point there. Fantastic there.
Always best to start with the clinical. Yeah.
With the hand. Right. The next question. Firoz.
A key advantage of MR angiogram over CT angiogram is a better calcification visualization, no radiation, a higher spatial resolution, and a faster scan time.
Yeah, so there's some hesitation in the answering, but yes. Okay, Dr. Vijay, you can start off by telling a lot of people are talking about calcification visualization being the answer. Your comments?
Yeah, calcification is better seen with CT
Yes.
angiogram.
Yes.
And the self-explanatory radiation and contrast risk is not there with MR angiogram.
Right. And both C and D is much better for CT. They got a better resolution. They've got a better, very fast scan time. All of you are familiar with CT and MR. You just get in and get out for CT. And MR takes that usual 15-20 minutes of time and no radiation. But at the cost of certain, you cannot see the calcification, which is very, very common in peripheral artery disease. What do you say, Dr. Firoz?
Yeah.
Right. Okay. So that's the correct answer is no radiation. Dr. Firoz.
So the duplex ultrasound advantage, high spatial resolution, hemodynamic assessment, detects the calcification better than CT angiogram, and no operator dependence.
Okay, so a lot of people are getting it right, Dr. Bijoy. Again, we talked about calcification. So what kind of hemodynamic assessment are we talking about?
You can assess the peak systolic velocity
Right.
with the spectral Doppler.
Right.
And if the peak systolic velocity ratio If it is more than 3.5, it suggests 75% critical stenosis.
Oh, okay.
If it is more than 2, 50% narrow. Such a hemodynamic assessment also we will get with nuclear ultrasound, because it uses B-mode ultrasound, spectral Doppler, as well as color Doppler. All the three are used.
Perfect. The others are all anatomical imaging. They're all anatomical imaging, and here you actually get a feel of the hemodynamics involved. Perfect, perfect. Fantastic. So I think everybody is on the same track here. Right. Dr. Firoz.
So the monophasic waveforms in Doppler indicates normal flow, high resistance, proximal significant stenosis, or a distal occlusion.
This is a common report which we see every time in the Doppler report, Dr. Bijoy. So your comments, please.
Yeah, proximal significant stenosis is the right answer. And normal flow, you just directly see. Distal occlusion, if there is no proximal occlusion, waveform should be normal.
Right.
So high resistance, velocity will increase, but monophasic form.
So monophasic shows significant ischemic response over there. Okay, so I think Dr. Bijoy, all of our delegates are very much in sync with our topic. So most of us are getting the right answers here, except for a few. That's okay. They are the ones who are hungry, so that's fair enough. Right. So that's the right answer. Okay.
So the next question is ABI value considered diagnostic for peripheral artery disease is less than 1.4, less than 0.9, less than 0.7, or less than 0.5.
1 to 1.4 is normal, less than 0.9 is the normal answer.
Right. So yeah, that's a very easy one. So what about that less than 0.5, less than 0.4?
Less than 0.5, severe indicates severe peripheral artery disease.
Yes. So I think it also comes into the classification of CLI or chronic limb-threatening ischemia. It's less than 0.4 to 0.5. Yes. So very important screening test, the ankle brachial index. Very much available in most of our diabetic clinics as well as vascular clinics. Right, so that's fantastic. So any questions, feel free to type in, and our expert faculty, Dr. Firoz, cardiologist in our department, and Dr. Bijoy, a senior consultant here, will be obliged and happy to answer any questions related to peripheral artery disease before we move on to the next topic of the day.
Yeah. Vijay sir, I have a question.
Yeah.
I have a patient whose creatinine is 2.6. So he has got a peripheral artery chronic limb ischemia features with a non-healing ulcers, all those things. So what would you suggest, whether to go for a conventional our CT angiogram or CT you will suggest, sir?
We will go for, because if the patient has indication for revascularization, if the patient has a limb-threatening ischemia, I will go for conventional angiogram. Usually I will be doing a hybrid angiogram with carbon dioxide angiogram for the upper vessels. That is, aortoiliac and femoral can be done with carbon dioxide.
I'd like to interrupt you there. For the benefit of a lot of people, I'll speak on their behalf. How the hell can you put carbon dioxide as an angiogram?
Carbon dioxide gives a negative contrast. It is a normal component of the blood. It will be absorbed to the blood, and it gives an adequate opacification of the proximal vessels. But it should be only used for infradiaphragmatic angiograms only. If it
So carbon dioxide angiogram, for those who are not familiar, is a modality which we use for all the CKD patients without traditional iodinated contrast. We're able to do very good angiograms. It's very routinely done in our department, and this is an option for what Dr. Firoz just mentioned. Especially if you want to choose CT versus the conventional angiogram, CT will involve 100 ml of dye, 100 ml of contrast. Whereas if you go for the conventional angiogram, if like Dr. Bijoy said, a hybrid approach, we take in a catheter, use carbon dioxide, only a little bit, 5 to 10 ml, to look for the infrapopliteal or near the foot vessels. Am I right? So a hybrid approach angiogram is what we do. So we have got some questions on screen. Firoz, let's highlight some important ones.
Lots of our young, they are hungry actually.
Yes.
So do coronary angiogram is required for all patients in peripheral artery disease?
Yes, we'll quickly answer one sentence for each, because we've got.
Not required. actually, because it should be symptom directed or else ECG or echo directed. If there is a suggestion of coronary artery disease, you should do. Otherwise, no need.
Yeah.
Acute occlusion prefers CT. CT angiogram should be done for acute occlusion, but we will be doing conventional angiogram to see what has happened. And you should revascularize immediately for acute occlusion because it is a limb-threatening emergency.
And the clinical relevance of ABI more than 1.4 with non-compressible arteries, should we start antiplatelets in such
Any
patients?
patient with suspected peripheral artery disease should be given a single antiplatelet.
Yeah. So,
1.4 non-compressible artery is likely to be calcific and you have to give antiplatelet.
so how long have to take?
It is lifelong.
Yeah.
It's like a PAD is like a CAD equivalent. You have peripheral artery disease. It's like you're having CAD, and you take your high dose statins and you take your single antiplatelets for life. Case closed.
Yeah, medical management of peripheral artery disease, all drugs which has to be given for coronary artery, single antiplatelet, statin,
Fantastic.
and antihypertensive, diabetic treatment should be given, along with symptomatic treatment, which is cilostazol.
Is carbon dioxide angiogram costlier?
No.
No, very cheap. It's gas, right?
So the drugs to be prescribed for the patients with heart failure with peripheral artery disease as cilostazol is the heart failure.
No other drug replaces cilostazol, but it cannot be used in.
Yeah, so with patients with heart failure, it's not a big deal actually. Cilostazol is an antiplatelet drug. It's not a big deal. The principles of management are anti-platelets and statins and your rheolytic modifications, nitrates, anything you can give. So it's not a big deal. And beta blockers, sometimes there are some people who say that it's not a great idea for peripheral artery disease, but it's not very solid evidence over there.
Previously, pentoxifylline was given, but
Yes.
just not that actually.
Yes. So let's see if something else. What about looking for a femoral bruit in aortic occlusion?
Yeah, should be. All the clinical
Yes.
things should be done prior to investigations.
Why is ABI a poor index in assessing PAD in patients having diabetes?
Because of medial calcification.
So a lot of calcifications, you may not be able to compress the vessel. Fantastic. Role of thrombolysis, Dr. Bijoy.
Acute limb ischemia, whether it's thrombus, you have to thrombolize.
Acute limb ischemia. Fantastic. Calcium channel blockers.
Calcium channel blocker doesn't have a specific role in peripheral artery disease unless it is indicated for coronary artery disease, where there is contraindication to beta blockers.
Fantastic. How fast PAD elevates the progression to CVD? This one here. Yeah, so I think that's not a very relevant thing because it could be coexisting. It could be coexisting, it's very often coexisting. But as Dr. Bijoy, if it is clinically indicated, we go aggressively. There are some operators who actively pursue coronary angiogram, but then again, yes. Toe ulcers with very distal arterial involvement, are interventions beneficial?
If there is evidence of critical limb ischemia, interventions. If you increase the proximal pressure head, the ulcer is likely to heal.
Yeah, so just to give you an idea, so they're talking about arterial intervention. So we can intervene up to the ankle, right? So you have the 3 arteries, infrapopliteal arteries. We do regularly interventions up to the ankle. Below the ankle, I mean, nobody goes in the dorsalis pedis and those, the foot vessels are a little small, although pedal arch recanalization is also a possibility. But yeah, generally up to the ankle is what we do.
Yeah, we have done pedal arch.
Yes, we have done,
recanalization.
yes. He has done, correct. It's very-
Safest beta blockers in PAD? Sir?
Beta blockers are not absolutely contraindicated in peripheral artery disease.
Chances of reocclusion after intervention. So that's the last question. Chance of reocclusion after intervention in PAD in spite of taking lifelong antiplatelets. What to do to improve the quality of life of patient?
We have to continue with antiplatelet and all drugs, and repeat procedure if needed has to be done. Drug-coated balloons have come, which can reduce the restenosis risk.
Yeah, so it's like it's not only antiplatelets which take into account one's patency of the arteries. It's like coronary artery disease. You smoke and you take antiplatelets, doesn't make any difference. If you smoke, you'll reocclude. If your diabetes is not controlled, you'll reocclude. If your obesity, your hypertension, your dyslipidemia is not controlled, it's going to reocclude. It's like coronary artery disease. So it's not based on lifelong antiplatelets. Even after an intervention, the 10-year patency rates are 70%, 30% reocclude because of the anatomical specialty of the lower limb arteries. So that's how it is. So coronaries, the reocclusion rates are 1%. For lower limb arteries, the reocclusion rates are to the tune of 20 to 30%. That's primarily because of the length of the muscle involvement over there. Okay, unhealed ulcer mostly presents to surgeon. Is revascularization done by cardiac department usually? Dr. Bijoy.
Yeah, we are routinely revascularizing.
Yes, it is done by the Department of Cardiology here in our hospital. All our surgeons and our plastic surgeons are very much in sync with us. And when they see a non-healing ulcer, they look for ABI, look for Dopplers. If there's any signs of a vascularity problem, we come into the picture, and we have the comprehensive foot care clinic to help these particular situations. And to limb salvage is the key in all sorts of ischemia, especially critical limb ischemia. Fantastic. I think we'll wrap up today's session for peripheral audio. Thank you, Dr. Bijoy, very much. Thank you, Dr. Firoz.
Dr. Vijay sir, for that wonderful overview of the peripheral artery disease. Thank you.
Thank you, sir, once again for that wonderful moderation session. Before we move on, stay tuned till the end of the program, everybody. There's something interesting coming up during the wrap-up. Moving on.
Before we begin, another familiar clinical question. My calcium score is high, doctor. Does that mean I have a block in my heart?
To take us through the basics of cardiac CT and what these numbers really mean, I would like to hand over to Dr. Salman, sir, to take over. Sir, the stage is yours.
The stage is mine. Really. Right. Good morning again. You'll be hearing a lot of me, unfortunately. Right. So we're going to talk about cardiac CT. Let's see if this is working. Yeah. So a lot of us hear a lot about, I don't know, a lot of health checkups are happening in the city and abroad, where a lot of people are doing cardiac CT checkups, calcium scores, CT coronary angiogram. People are asking, youngsters are asking. There are a lot of people on social media saying, I want to do a CT angiogram. What's the fundamentals? What are the basics here is what we're going to be discussing today. So we all know that heart disease is the #1 killer, okay? And the point number 2 is that a lot of patients have normal stress tests and still have heart attacks. And lesions which were mild to moderate stenotic still can get MIs. So that's a big problem. So, and chest pain is one of the top 3 reasons for a GP visit. Okay, missing CAD is catastrophic. And we need to answer these questions which cardiac CT helps. Is this patient low, intermediate, high risk? Do they need a cardiology referral? And do they need aggressive medical therapy? So the 2 things which we're going to be talking about today is CT calcium score and CT coronary angiography, right? Okay, so CT calcium score, okay? How many of us have heard about CT calcium score? I think you should put the poll, then only you'll start answering. Okay, so not many of us have heard calcium score. Okay, so that is interesting because it is one of the most commonest tests which is now being referred as an executive or general health checkup plan. So basically, it's just like a plain CT, like a modified X-ray kind of a thing. It measures the calcium deposit within or on top of the arteries is what I would say. The score's name is called the Agatston score. It's, as I said, it's non-invasive. There's no, and it is a tool for predicting cardiovascular risk. It's very, very important what it does. A lot of people come to us today asking, I'm going to get a calcium score. Do I have a block? Okay, so the key message is that it does not detect blockages. It predicts cardiovascular risk. Okay, that's an important point. I'll get down to that. Now, who should you order a calcium score? So who should get a CT calcium score is basically any 40 years plus guy who's asymptomatic and who has some risk factor like diabetes, some family history, he's a smoker, dyslipidemia, hypertension. So he wants to know his cardiovascular risk or the future risk of developing a heart attack. Now, if you already have an acute chest pain, he's already a known CAD, post-PTCA, has a CABG, or very young, it's not clinically indicated. So you already know you're already a cardiac patient, you don't need to know your cardiovascular risk. Okay? So I want to get you familiar with this particular thing, which is very important for all physicians, all general practitioners, all residents. What is the ASCVD risk calculator? Atherosclerotic cardiovascular risk calculator is something which all of us should be doing above the age of 45. If a patient comes to you who is asymptomatic, like for example, I come to your clinic and I ask you, doctor, can I get a heart attack in the next 5 years? So you should have a learned, objective opinion on how to do that. So you have risk calculators which are freely available online, and based on several clinical parameters, you calculate your risk as either low, borderline, intermediate, or high. Okay, if you have a low risk by your calculator, that means you're pretty good. If you have a high risk, you need to be on primary preventive modalities like aspirin, a statin, or other modalities to prevent further cardiovascular risk. When you are borderline, so the risk tells you that your 10-year risk is 5%, your 10-year risk is 7.5, your 10-year risk is less than 20, then this is how you predict. So this is called intermediate or borderline. Here it's a gray zone. So if my score comes at 7, so you are going to tell me, Dr. Salman, you have a borderline score. So I'm thinking, what does borderline mean? Will I get or will I not get? If I get a score of 25, you have a high risk, Dr. Salman. If my score comes at 3.5, you're pretty safe. Enjoy your life. So here, that's where up regulators or down regulators come. So here you do a calcium scoring where you can upregulate or downregulate your cardiovascular. That is the utility of a calcium score. So this is how a calcium score looks. This is an axial shot of the heart. Okay, this is the aorta, this is the pulmonary arteries, and these are the coronary arteries. So there you can see the left main over there. There is no calcium, and here this white is the calcium. So the computer automatically calculates and quantifies the amount of calcium and tells it to you in the form of a score. So the left over there is a calcium score of 0. There's no calcium on the coronary arteries. Here, there's a calcium score of 1,200. Lots of calcium, which you can see over here. This is the left descending. This is the right coronary artery. A lot of calcium over there. Again, I want to tell you, it doesn't mean that the patient has got a lot of blockages. It means that a lot of atherosclerosis is happening. A lot of calcium deposits is happening. A lot of atherosclerosis, therefore, is a high cardiovascular risk. Right? So you have no calcium, 1 to 100, sort of mildish, 100 to 300, moderate, and more than 300 is moderate to severe CT calcium score. So this is how the computer detects it. There's a density factor, look at the quantity of calcium, and then makes an Agatston score, which is an automatic report, right? So how it is done for us over here, you just walk in to the radiology department and say, I want to do a calcium score, you get it done, you get to the CT machine, one shot, and you're out, and you come to see one of us to understand your score. So if you have a calcium score of 0, very low 10-year risk, okay? And so you could probably repeat a calcium score another 5 years to understand your cardiovascular risk. So it's like, I tell my patients, it's like looking at cholesterol. Now, why does one look at cholesterol lipid profile? To understand if you have a cardiovascular risk. High cholesterol means I have a cardiovascular risk. So high calcium score means you have a cardiovascular risk. So it's something akin to that, to upregulate, to get added information whether you have a cardiovascular risk. 1 to 100, as I said, you may need to start statin therapy. 100 to 300 means basically it's a decision for you to start statin therapy for primary prevention of a future cardiovascular event, right? And more than 300, basically the atherosclerotic burden is likely to be very high. You definitely need to start on a statin, an antiplatelet, and you may need a cardiology referral to look for a stress test, etc. And depends on symptomatic, you may need other tests like a CT angiogram or other evaluations. So that's a basic nutshell about what a calcium score is. I hope you guys understood. The next part of cardiac CT is a CT coronary angiogram. So that was a calcium score in the CT. This is a CT angiogram as such. So where we actually put in an iodinated dye intravenously, and you actually get the beautiful pictures of an angiogram, which help us to understand whether the person has an actual block or not. The calcium score doesn't help us to do that. This one helps us to do that. So basically, it's ECG gated, and it's a contrast enhanced scan, like a CECT of the heart. It's got an excellent negative predictive value. Means if the CT says that it's normal, it's normal. You can just finish the evaluation for cardiology from that point of view. Okay, it's fast and it helps being that it's an outpatient test, right? It's one of the best non-invasive tests for do that. So who to refer for a CT coronary? Can anybody go for that? So ideally, it's the low to intermediate risk category, right? So low to intermediate risk means patient has some atypical features, not very high risk. For example, if I'm a diabetic, I'm a smoker, I'm a hypertensive, strong family history of heart disease, and I have an effort angina of 100 meters, the likelihood of CAD is very, very high. So I would rather refer myself for an invasive angiogram because the likelihood here, the next level, atypical chest pain, 40-year-old guy, No, not much risk factor, but still he wants to know why his chest pain is happening. You go for a CT. Very typical symptoms, rest angina, not for CT, right? And atypical chest pain is the classic indication, especially when the TMT is a little unequipped. As I said, it's not ideal for MIs, uncontrolled tachycardia, and of course, renal dysfunction. So here the importance between stress test and coronary CT angiogram. Here you can see the plaque. You can see the plaque quantification. You can detect who's got the vulnerable plaque. Early disease, you can catch early disease, plaque burden, and it's good for ruling out coronary disease. How about a TMT? That's the most easiest, cheap and best solution for coronary artery disease. Now it shows you whether you have a significant coronary artery disease. For just a rule of thumb is, if you have more than a 70% disease, you will be caught on a treadmill. What if I have an early plaque? Youngsters, less than 40 to 45, you have an early plaque. A TMT is going to miss it. A CT will catch it and you can start primary prevention. And that's the importance of doing an anatomical test in the particular thing. So technical requirements, you need basically a little bit of beta blockade or an ivabradine to reduce the heart rate. Regular makes good clarity. This is a technical thing, and a little bit of breath holding. So a lot of COPD patients, if it is a COPD issue, then you may have some blurring of clarity. What does it tell you? Presence of plaque, okay, soft plaque, higher risk, a lot of characterization for plaques, degree of stenosis, right? This is how it looks like, So for example, look at the screen over there. So that's the right coronary artery. So a very narrow kind of, you can actually very beautifully delineate the plaque over here, the soft plaque, non-calcific, which is again confirmed on the coronary angiogram. So this is not very tight, something like a 40% stenosis. But that patient, this guy would be missed on a treadmill. He would pass the treadmill, but he's got disease and he needs aggressive statins for it to prevent from progression to a 90% around a couple of years from now. So that's what it is. Okay, so high-risk plaque features, which is the vulnerable plaque? It's a $1 million question in cardiology. Vulnerable plaque means certain plaque features are there, which has got these signs, the top 4 signs. These are the plaques which can rupture and form the MI tomorrow. So those are the $1 million question in cardiology. I have a 50%. So like I said, if I have a 50% plaque in my LAD, it can still rupture and become an anterior MI. It's not only the 95% disease which causes anterior MI. A 50% plaque, if it has got any of these factors, it can cause acute plaque rupture and cause an MI. So that's a big problem. That can be caught on CT, right? And so if the CT is normal, excellent prognosis. Mild disease, start your statins and other lifestyle modification. Moderate disease, you may need to do a stress test. Severe disease, you need to go for an invasive angiogram. So as I said, the old model, one used to think that only tight stenosis or 95% stenosis is very dangerous. No. A vulnerable plaque, which is not necessarily obstructive, also needs treatment, right? For example, a 40-year-old painter, exertional right-sided chest pain, dyslipidemia, mildly positive TMT. So he's confused because you said a mildly positive TMT. So a CT coronary angiogram is ideal. So this is how it comes out. This is how a CT looks like. You send for a CT, you get it, and you see beautiful pictures which suggest that there is no coronary artery disease. You get a stretched view of all these images which shows that there is no coronary artery disease. Okay, so this is a 45-year-old surgeon who's got intermittent postprandial chest pain. ECG is normal, echo is normal, but he had a knee surgery. Therefore, he can't do the treadmill, but he's still worried about his chest pain. Go for a CT, and this is what the CT showed. A tight proximal disease in the LAD, which you can see there. Very tight critical disease, which was the cause of his chest pain. We did an angiogram, 99% disease. After angioplasty, it was recovered. So those are the utility of those patients who cannot do a treadmill. Excellent modality for post-CABG patients to look at the grafts. You can see the Lima to LAD. These are how the grafts look like. This is the Lima to LAD. This is the saphenous venous graft to RCA. Very good for delineating all the grafts in one go. All my patients after 10 years of CABG undergo a CT to look for patency of grafts. Aortic assessment, very good for the other non-coronary stuff. For aortic dissection, look for dissection. We all know that. This is a gold standard. Aortic aneurysms, this is before stent repair. This is after EVAR, endovascular repair, which we done a couple of years back. This is again an endovascular repair for an infra-abdominal aortic aneurysm, after repair, before and after. This again endovascular aneurysm repair. Very good for peripheral arterial disease like Dr. Bijoy mentioned. CT can also be used for pulmonary embolism, gold standard. And the great triple rule-out test is an acute chest pain in ED to rule out dissection, ACS, pulmonary embolism, is called the triple rule-out test. These are the modalities for cardiac CT. Thank you very much. I'll
Thank you, sir.
I'll end up moderating my own session. So
Thank you, sir, for that insightful talk. I would now like to call upon Dr. Anwar, sir, to moderate the session.
Hi, Anwar. Have a seat. Yeah, you can do the first question.
So let's go to the questions. First one is the primary role of coronary calcium score, CSC, in asymptomatic patient is to detect degree of coronary blockage, predict future cardiovascular risk, measure myocardial viability, and detect arrhythmias.
Yeah, so all of us are back on menti.com. Go to your web browser in your phone. Those of you who have come in late, go into menti.com. The number on top of the screen or on the side TVs over there is 35345737 and enter, and then you'll get us live onto this particular audience poll. Yes, so a prediction of future cardiovascular risk, all of us have gotten the concept that calcium score is not for a lot of patients. I don't know how many of you see, there's new fancy labs which have come up in the city. They come up with a calcium score, they come running to us saying, I got a lot of big blocks. Please help me, doctor. But it's not like that. It's prediction of cardiovascular risk. That's what you should understand. And basically, you start your statin, start your aspirin, do a treadmill test, and move on in life. Fantastic. So that's the right answer. And it's a risk prediction tool, not a test for restenosis.
Next question. Calcium score of
0.
Calcium score of 0 in an asymptomatic patient generally indicates no chance of coronary artery disease, extremely low short-term risk of major cardiac events, need for immediate CT coronary angiogram, severe stenosis likely.
So that's an important point here, right? So there's a lot of confusion, Dr. Anwar, between A and B. People are getting confused. A lot of us have got the right answer that the low risk of future events. Now, for the 17 people who thought that there is no chance, that is the wrong answer. You know why? So again, calcium score does not detect blocks, okay? For hypothetically speaking, there is a young 40-year-old guy who's got significant disease, but he doesn't have calcium on his coronary arteries. He will be missed. He'll get a calcium score 0, but he can still have blockages. It's a rare occurrence, but it can happen theoretically, meaning very young people don't start to develop calcification. So no chance of coronary arteries is not the concept here. Again, whatever calcium score depends does not mean that you have or do not have blocks. It's just your risk assessment. Just to give you a small example, the converse also. One of our doctors here in our hospital, his father came to me with a calcium score of 3,000. So 3,000 is not pakka, he'll be having block. If you did an angiogram, it was okay. Why? Because he had dense adventitial calcium. Dense adventitial calcium, but there was no luminal stenosis. So he had atherosclerotic phenomena, he had a stroke, but he didn't have heart disease. So this also shows you burden of atherosclerosis. That's what it shows. So it's not no chance, less chance. And the answer is low short-term risk. Fantastic. Great. CT
coronary angiogram is particularly useful after an equivocal TMT because it evaluates only ischemia, offers a definitive anatomical clarity on coronary stenosis and plaque, does not require contrast, always replace invasive angiogram.
Yes. So equivocal TMT, what I mentioned, so basically you have a treadmill and somebody says it's a borderline case. It's a borderline case, what to do? It's always a confusion for the cardiologist and for the physician. If it is a strongly positive treadmill, definitely you have something abnormal. So when you have the mildly positive treadmills or the equivocal borderline cases, you need something better. So therefore, you get anatomical clarity, right? To understand whether you have obstructive CAD or not. A lot of times, especially ladies, have a false positive treadmill test that how to upscale. So when you have a mild positive, you need to do another test. Either you go for an invasive angiogram or an easy CT coronary, especially if it is a low risk individual. So that's why it is useful after an equivocal TMT. Fantastic, great.
Next question. One major advantage of CTCA compared with stress test is it measures exercise tolerance. It directly visualizes coronary anatomy and plaque morphology. It detects only severe blockages. It does not require contrast.
Yeah, so this is again self-explanatory. It's like we said earlier, this thing, coronary anatomy and plaque morphology is very well described in a CT coronary angiogram. So just to understand, like I mentioned, how do you refer for a CT calcium score? It's just very easy, no preparation required. For a CT coronary angiogram, you need a little bit of preparation. Two things, or three things rather. You need to have a serum creatinine, which is sort of okay because you're injecting dye. Number two, you need 4 hours of empty stomach or fasting. And number three, you need some kind of heart rate control. If it's on a beta blocker, it's fantastic. We usually give ivabradine to all our patients the night before and the morning of the test so that you get a good resolution CT angiogram. Yeah, that's just how we prepare for a CT coronary angiogram in our department of radiology over here. Fantastic, great. So any questions on CT, please feel free to type. So it was just basically a nutshell to understand which are the modalities where we use cardiac CT. I thought this topic was relevant because we get a lot of referrals from executive health checkups in the city where calcium scores are being done very frequently, and I think you guys will also be flooded in the days to come because it is being promoted as a very fantastic test, a quick test, a CT calcium score. So you should know how to interpret a calcium score is. Yeah. So we've got a few questions. Yeah. So one person has very remarkably corrected that all the answers were second option. Yes. So I'm being very lenient over here so that you guys don't have much difficulty. Dr. Anwar, they are appreciative of my leniency. Let's get some questions, Anwar. What do you want?
Age specification for CT angiogram.
No, so there's no age specification. I mean, generally we say, our cutoff for all cardiovascular disease according to guidelines starts above 40. Unfortunately, we have been starting seeing patients left and right in between 35 and 30 to 40. But that would be case-based thing. But yeah, there's no age specification as such. If you think it's required, if you have some suspicion, go for it. Yeah.
Sir, suppose if there is a patient with a 45-year-old patient with high family history,
Yeah.
strong family history, without symptoms,
Yeah.
how will you proceed?
Yeah. So it's a perfect thing, no? So basically, family history with strong family history with no symptoms. So the first and foremost thing which I would do is to screen for risk factors like diabetes, hypertension, dyslipidemia, smoking, and then treat those, and then do some form of coronary testing. So that could be a stress test or an anatomical test. I tend to do on that order risk factor assessment, stress testing, and then have a very low threshold for doing something like this, whereby you can find out the early plaque burden and then start aggressive statins if it is there. Like for example, if you have even a 20% plaque in your LAD, that's some motivation for you to start your statins, right? I have a 20% plaque in my LAD with a CT, and so I am on statins in spite of me having a normal lipid profile. So that's the kind of understanding which we should have for aggressive risk, this thing, right? So does taking calcium have increased coronary risk? No, there's no evidence for that, right? Do we need to repeat CTCA again? Then when? It's not something very repeatable because of the radiation risk. Yeah, so I think it should be a one-time affair. A calcium scan, a calcium score, if you are 0, you can repeat it after 3 to 5 years. If you have any score, but then I don't think it's worth repeating because you know where you're standing.
Can you show the slides again which mention the recommended interventions based on?
CT calcium, yeah, we'll get down to that, yeah.
Do we need to repeat CTCA again?
Yeah, we told that, yeah. CAC price, CTCA price. All very cheap stuff, man. Cheap and best. Calcium score
Whether
cost.
CTCA can replace CAG?
No, they want to know the price. They're very interested in the price. Calcium score, it costs something around $3,000 for calcium score. Our fellow guys in the city charges $9,000, but anyway. And a CT coronary angiogram probably some $10,000. That's it. Whether CT can replace CAG? Yes. In the future, we don't have to talk about the future because CT coronary angiogram is a very old test. It's nothing new. But we are getting better and better machines day by day. You're getting better machines, better quality. You don't need heart rate control. Like, for example, the new machine which we are going to acquire next month, you don't need any heart rate control. You just get in and get out. It's a 3-second acquisition. So replacing CAG is not going to happen because you need to do interventions, you need to do an angiogram. So it's not going to replace it as such. ECG shows RBBB. Should we request CTC? And no. RBBB is not a sign. Only if you have QRBB, it's an anterior MI, in which case you do an invasive coronary angiogram. What is the minimum dose of statin? I think that's not very relevant here. Yeah, so it's like cardiac MRI question mark. Good question mark. It's a good test. Out of scope, out of syllabus. Is there an MR angiogram? For coronaries, it's not a well-described test because of the motion artifact, continuously motion artifact, CT catches it better. Cardiac MRI can do perfusion studies for the myocardium. Have you done CTCA? Personal question. Yeah, I already told the answer. Yes, I have done, I have a 20% plaque in my LAD, hence I'm on a statin. Yes, that is the answer. How do you see the role of advanced imaging modalities, the IVUS, OCT, FFR evolving, improving clinical decision making, especially in borderline lesions? That's an advanced level question by somebody involved in cardiology, probably one of my staff, I think. So, yeah, so those are all, for those who don't know, these are all invasive modalities. Yeah, so but again, for borderline lesions, invasive model, all of these are used for addressing borderline lesions, but I think it's out of scope of this topic. Mild ischemia detecting TMT, which is better, angiogram or CT? Yeah, so if it is a low risk individual, I would go for a CT. If it is a high risk individual, like diabetic, smoker, dyslipidemic, hypertensive, family history, I would go for an invasive angiogram, or if it's symptomatic, invasive coronary angiogram. Okay, so I think we'll wrap up that round. Thank you very much, everybody. For one more question by Dr.
You didn't mention about how to calculate ASCVD.
Yeah, I did mention. You were sleeping. Yes, so ASCVD risk is by an ASCVD calculator. There is a calculator. So there's a calculator which is available online. So like this, for example, you know, if I just type ASCVD risk calculator on Google, okay, so you're going to get this, you know, ASCVD, this is the American College of Cardiology, a lot of risk calculators are there. So you get into that, so they will ask you for a lot of basic questions, you know. So they will ask you questions about your age, sex, race, BP, cholesterol, diabetes, and then they will calculate your 10-year risk of ASCVD according to whether you're low, borderline, intermediate, or high. And based on this, whether you need to go for primary preventive modalities or not is the ASCVD risk. And when you're intermediate, whether you want to upregulate your risk or downregulate your risk. So if I come intermediate, and then I have an indication for statin, I should take it. But then I am not very interested in taking a statin. So I do a calcium score. If I get it 0, then I can down-regulate my risk. I become low risk. Okay, even if I'm borderline, if I get a calcium score of 0, my risk becomes down-regulated. So I'm a little protected. I am borderline. I have a calcium score of 1200. My risk becomes upregulated to a high risk. And therefore I need more. So that's how calcium score down-regulates or upregulates your ASCVD risk. Fantastic. Thank you very much, ladies and gentlemen. Right. Salim.
Thank you for that wonderful moderation, sirs. Before we dive into the next session, just a heads up, our annual crowd favorite quiz is coming at the end with some exciting prizes, so stay tuned.
Gold and diamond prizes.
Yes.
Moving on to the next session. A question many curious patients and sometimes even we ask. Doctor, I heard about a capsule pacemaker. What exactly is that?
So, for a quick tour through the latest innovations in cardiology, we invite Dr. Sandeep Mohan, sir. Over to you, sir.
Thank you. Good morning, everyone. So, this is a slight deviation from the basics of cardiology. I can see that a lot of your brain ATP is circulating around with the sessions that have already been completed. So, even though this is not the basics, no basics in any subject is complete without knowing about the innovations. You don't have to learn about them, you don't have to do them, but you have to be aware of them. So we decided to give you a short session on what is available in latest innovations available in interventional cardiology. And you will be also, this will be actually a continuation towards the next session, which is a workshop. You can see we have arranged a few things in the backside for you people to see and even touch. So we'll go into the session right now. Yeah, so there has been a lot of innovations in cardiology, mostly on diagnostics, monitoring, therapeutics, and in interventional cardiology. And there's a lot right now going about on AI in interventional cardiology. And okay. Yeah. So digital health is the future. We have now wearable pulse rate monitors, BP monitors, wearable ECG monitors, and even AI integration into ECG and echo. So coming into the innovations in cardiology, we know that coronary angioplasty has come in 1970s. Initially, the procedure was to get into the coronary vessel, put in a wire, identify the lesion, and just do a balloon dilatation. But now stents have come up. We now have first generation, second generation, third generation drug-eluting stents. But what is new in the market? So it is not just about So it is not just about putting in a stent and removing a lesion. It is also about trying to avoid metal into the heart. So the latest thing in the market is the drug-coated balloon. We do it a lot for our patients nowadays. This is to avoid a metal piece into the heart, which can cause a lot of instant restenosis. You should have heard of people who get later on blocks into the stents which have been previously deployed. So one mechanism for this balloons is that you dilate the vessel just like we dilate any other vessel, and this balloon will elute chemicals and agents that will prevent the recoiling from happening. What is the advantage? There is no metal. It maintains the natural vessel condition, and it is especially useful for small vessels and instant restenosis. And you might also have experienced people who come to you for dental fitness, for other procedures, where you might have to stop antiplatelets. So if you get away with a drug-coated balloon rather than a stent, you can actually stop antiplatelets in a more confident fashion. So this is one trial that has come on this year in 2025, present in the AHA, which shows that DCB is not inferior to stents in a lot of people who request coronary angioplasty. We are one center who is recruiting patients in a trial, a large-based trial in India, and we are actively doing DCB for around 10 to 20% of patients in our routine angioplasty. The next thing is how to deal with complex angioplasties, how to deal with complex calcifications. A lot of these patients will have to go for coronary artery bypass surgery. So many of these patients nowadays, if someone asks me, if what do you want, angioplasty versus bypass surgery, I would tell them that I don't want my chest to get cut open right now. You can do that in future. If you have any other option that you can do transcatheter wise, you give me that. So we have options where we can modify this excessive calcium, excessive difficult plaques that are difficult to be opened up with just a balloon and stent. So one is the OPN balloon. It's not just a balloon. These are double layered coated balloons which go to very high pressures and help in breaking the calcified plaque. And then there are other modalities like the laser therapy, ablation therapy. These are new words for you, I know, but these are things that we routinely do nowadays during our angioplasties, and you should be aware of it. So this is an example of a rotablation. You can see that when there is a calcified plaque and when we are not able to get through with the usual balloon angioplasty, this particular instrument helps in drilling and sanding the lesion. It is not just breaking up of the calcium, it is just sanding off of the calcium. You can see materials getting dispersed into the distal circulature, but this will get disappeared into the microvasculature. And once the sanding is done, we can put in a stent. This is a newer innovation called the orbital atherectomy. It is just like rotablation. We have diamond burrs on that thing which is rotating, but this is a bit more safer than the rotablation, and it helps in treating larger vessels. You can see the orbit that the thing is taking, and you can see the way it is breaking off the intimal calcium, medial calcium, and this helps in better lesion preparation, and so that we can deploy a stent without much difficulties. So this is also something we routinely do, but it is expensive, and we should counsel it for only patients who are not candidates for bypass surgery. And this is the latest thing in the market in India, even though it is not a latest innovation. It has been there in the market since 10 to 15 years in the Western countries. And the advantage is that it pulverizes the lesion. Many a times we will not be able to cross the lesion with a balloon because it is so hard, and even a rotablation does not work. This is some situations where we can cross the lesion. We have to cross the lesion with a coronary wire, and then we pulverize the plaque with such an instrument called the laser, which uses a 308 nanometer wavelength. It treats by mechanisms called photoablation, photochemical effect, photothermal effect, And finally, it makes us a pathway. So once the pathway is set, it is easy for us to treat the vessel with a stent or a DCP, whichever is required. So after we have discussed about the calcium modification, this is one thing all of you should realize about angioplasty. Angioplasty is not just about putting in a balloon, putting in a stent and coming out. The current era of angioplasty is precision angioplasty. You have to know the correct length of the lesion, you have to know the correct size of the vessel, only then can you prevent future effects, future instant restenosis, future thrombotic effects. So that is when we use intravascular echo. This is intravascular ultrasound or an intravascular OCT imaging. We will demonstrate both of them to you people. We have an OCT console there, we have an IVUS console here also. And what we do when we do an angioplasty, you are actually going to see an angioplasty being done on the table right now. And this is very important to finally assess the result, because unless we have a very good stent deployment, as you can see in the OCT imaging here, these patients will come back to us with restenosis and thrombus. So we have to identify which patient has a malapposition. That is malapposition means a gap between the vessel wall and the stent. And under expansion means the stent should have expanded to a normal size, only then you are going to get longer term results. So the world of precision angioplasty means you have to use coronary imaging while you do an angioplasty. We try to counsel them for a lot of our patients, but we are able to do it only for a 30 to 40% because of the cost constraints in the current scenario. But when you consider the fact that these patients should not come back to us with another block or with another complication, it is always best to suggest a precision angioplasty for all these patients in the first sitting itself. So that is about angioplasties. Coming to non-coronary stuff, I'll just go through a few brief innovations. The most important thing, you must all have heard about TAVI. Previously how severe aortic stenosis is treated. We have to cut open the chest, we have to cut open the valve, and we have to deploy a new valve. So the TAVI came as a new procedure in 2002. The trials went up very fast, and ever since 2014 it is in the market. In India it is currently rapidly expanding. I'll just show how it is done. So all we have to do is get access to the aortic valve. How do we get access to the aortic valve? We go through the femoral artery, go up towards the aorta, aortic arch, cross the valve. So once the valve is crossed, we can deploy this thing just like we deploy a stent. For a simple case, it just takes 1 hour. No cutting open, no general anesthesia. Patient can actually even go back home the same day or the next day. So a major valve surgery is done just through the groin. So we actually do that. There are complicated scenarios also, and we have to do exquisite CT planning and proper patient counseling before doing this procedure. We are doing a lot of TAVIs, but the cost constraints again is an issue. We will be demonstrating the TAVI system as well in 15 minutes or so. So this is another new innovation. We have patients with severe mitral regurgitation, where sometimes medicines always may fail. So these people might require surgery to correct their mitral valve. They need to require a mitral repair or a mitral replacement. So this is another way we try to treat them by transcatheter wise. We go through the femoral vein. From the femoral vein, we enter the right atrium. From the right atrium, we puncture into the left atrium. Previous. That just play that. Yeah. So this is the instrument being used to puncture from the right atrium to the left atrium. And you know, once you get into the left atrium, that is the mitral valve. So that is a very leaky valve, you can see that. You place this particular clip there and clip it up. This will reduce the mitral regurgitation. This will improve the symptoms of the patients. You have to select the patient very carefully before counseling a transcatheter edge-to-edge repair for a patient. So there are several innovations in peripheral vascular disease also. Bijoy sir has covered a lot of them. DCBs, just like in the coronary system, drug-coated balloon, atherectomy devices. EVAR is actually not an innovation, but a lot of people with aneurysms and dissections might require intervention, which many times surgery is not possible. Just like Dr. Salman had earlier presented some beautiful CT images of endovascular, post-endovascular repair. This is how it is done. Again, you go through the groin, you place an aortic graft across the aneurysm, and you cover the aneurysm. You can even put extension grafts into the femoral artery to completely cover the aneurysm. You should be very careful that the arteries are not occluded. And if at all there is an aneurysm across major arteries like renal or visceral arteries, you might have to put fenestrations, which are pretty complicated endovascular aortic procedures. So once this is excluding the aneurysm, you have treated the patient and saved the patient from an aneurysmal rupture. Coming to arrhythmia management, this is going to be a bit extensive, so I won't go into details. I just want to introduce two important things that you must know about. One is cardiac resynchronization therapy. It is not a new thing in the market. It has been there for 10 years for heart failure patients. Now there is a lot of things going on where we don't want too much catheters inside the heart. So there's something called the left bundle branch pacing. So in conventional pacing, when we have to put a right ventricular catheter here and a right atrial catheter here. Nowadays, there is an option for us to put the pacing catheter right into the left bundle. This is the left bundle branch, you know about it. So once you connect the catheter into the conduction system of the heart, we get a narrower complex. So whenever we get a narrower complex, we try to achieve for a narrower complex for the patient, it is going to be good in the long run. Patient is going to have less symptoms and patient is going to have less heart failure. So this is the current system that has come up. Left bundle branch pacing has rapidly come up over the last few years. And another very interesting innovation that you should know about is the capsule pacemaker. It is a new thing in the market. We have a sample for you so that you can hold on to it, but don't lose it. We have only one. So this is only 2.5 centimeters in length. You can just imagine, instead of making a scar and putting in two catheters through wires and all, you just get a small thing right through the femoral vein, cross the right atrium and just put it there, just deploy it there. There's no scar, no infections, procedure time just 1 hour. We just did, the last procedure that we did just took 1.5 hours. So usually it is less than 1 hour and discharge even the same day. And it is a wonderful innovations, and it's just coming up because the battery life is an issue, and it is a new thing that needs more technical advancements. So there are lots of other innovations in medical therapy as well. I don't want to go into the details about the medical advances, but one thing again you should know that there is something called the sympathetic denervation for the resistant hypertension. You would have patients with lots of medications, hypertension still not getting controlled, 140, 90, 160, 90, 4, 5 drugs. These are patients where you can offer this particular treatment. You know that the renal nerves and the sympathetic system of the kidney is pretty important in the RAS activation, and these signals go into the brain. They send efferent signals down, cause vasoconstriction. So this system needs to be cut off for some patients. So that is how renal denervation helps. You again put a catheter to the femoral artery, go into the renal artery, and you ablate the renal nerves. Once you cut off that signal, these efferent signals from the brain will get stopped. So the hypertension can be relatively more controlled. Again, it is not to be advised for all people. You have to counsel in detail. It is only a class 2B indication as of now, but it is an option for patients who are not getting controlled with usual medications. So coming back to the take home, you have to learn the art of personalized cardiology. You cannot just give advanced hardware and the routine medications for all and each person. You have to individualize the patient. Do not blindly follow the guidelines and protocols. Individualize what the patient has with the problem, assess it, and then put the guidelines into the patient. Do not blindly use all the hardware. We have laser, we have rota, we have orbital atherectomy, but we cannot use that for all of our patients. 80% of our patients do not require it. Use it only when required, or you are going to fall into complications. And always individualize on the drug selection. The importance of ethical and judicial practice need to be emphasized because more and more innovations are keeping on coming, and we need to learn where to use it and when to use it. Thank you.
Thank you, sir, for that insightful talk. We'll now have Dr. Firoz back on stage to moderate the session.
Thank you, Sandeep sir, for that fascinating tour of the newer interventions in the cardiology.
So you can go back to menti.com. The code is on the screen in front of you and on the left and right flanks of your screen. And those of you who are interested can show us some love. We've got around 121 people online. Sandeep, to listen to your innovations. Right. Okay, Dr. Firoz, take the stage, please. Yeah.
So the primary advantage of TAVI for elderly patients compared to the surgery is better long-term durability, significant shorter recovery and lower initial risk, no need for anticoagulants ever. It cures all valve disease permanently.
Right, so there are a lot of people going the right way. Obviously, Dr. Sandeep, your comments, please.
Yeah, I think everybody has got the picture.
Yeah.
It is for faster recovery and lower initial risk. Yes.
Yeah, any take on the long-term durability, which a few people thought?
Yeah, so we are going to show you the TAVI valve right now. You should understand that this is not a metallic valve. This is a tissue valve, either bovine tissue valve or a bovine pericardial valve. So you should understand that all these tissue valves are degradable. They have a duration. They might last for 10 to 15 years, but some do last less, depending on the patient cohort, maybe 10 years or less. Depending, for some patient with chronic CKD, it's pretty difficult to put in a tissue valve because they degenerate fast. So there is a durability issue, but the good thing is, even if the valve degenerates after 10 or 15 years, you can put in another valve.
Yeah. So the take-home message there is, for those who should know, is that metallic valves have a lifelong durability, and bioprosthetic tissue valves, like Dr. Sandeep said, 10 years. What's the number which we used to quote? We've got brilliant valves coming in now with longer durability and all that, but still better long-term durability is not the correct answer. It is the topic of continuous innovation, but yes, shorter recovery and lower initial risk is the right answer. Right. So fantastic. A lot of people have got that. Firoz.
TAVI is most commonly performed for which patient group? Young patients with a bicuspid valve stenosis, moderate AR, mild aortic stenosis with LV dysfunction, and severe symptomatic aortic stenosis with prohibitive surgical risk.
Right. So a lot of people are going in that direction. Dr. Sandeep, some people talking about aortic regurgitation. Your points?
Yeah, so the correct answer is severe symptomatic AS with prohibitive surgical risk. This was the initial pakka indication for TAVI. Nowadays, the indications are expanding. You can even use severe symptomatic aortic stenosis with low risk. These trials are coming up where TAVI valves are, as Dr. Salman said, the TAVI valves are becoming more and more exquisite and longer lasting. So the indications are expanding, and you should not use any TAVI valve or a surgery for a mild aortic stenosis. It is out. And for young patients with bicuspid aortic valve stenosis, again, the issue is the durability. So preferably the TAVI is used only for a patient greater than 65 years. But if the surgery is not possible, there has been instances where young people has required a TAVI valve. Regarding aortic regurgitation, moderate AR can be treated medically only. If the AR is severe, the class 1 procedure is surgery. But there are options for putting in a TAVI valve in rare scenarios.
Yeah. So the trend, what is going on, if you understood what Dr. Sandeep said, if you have a borderline case, like say a 60-year-old or a 55-year-old, and the patient wants a TAVI, because he doesn't want a scar, etc. So you can put in specialized TAVI valves which are suitable for TAVI in TAVI. So 15 years from now, this is called lifetime management of aortic valve stenosis. So you plan a valve which will accept a new valve 10 years from now. This is called TAVI in TAVI, which is very commonly done right now because we've sort of become a decade plus. So the 10-year previous TAVIs have now going through a TAVI in TAVI. So that's called lifetime management of aortic stenosis.
TAVI is the next angioplasty. That is why we want you all to know about it.
Yep. Right.
So the situation where a patient might benefit from referral for laser angioplasty, a patient with a mild coronary disease on medical therapy, a patient refusing all medications, or a patient with recurrent symptoms due to instant raised stenosis.
Or the fourth column, everybody wants laser angioplasty.
So it's good that everybody got the thing right, because there has been a lot of controversies on laser angioplasty. We actually get patients who come to our OP, we want laser angiogram. so, so, so it's all about, because of a lot of misguiding YouTube videos saying that laser angioplasty is a solution for everything. So it should be used only when required, and it is especially useful for this particular cohort, in-stent restenosis with severe symptoms.
Yeah, perfect. So there is that category number 2, which I mentioned over there, is patient doesn't want to take medicines. That's a new upcoming cohort in Kerala population. Hello, Dr. Sandeep.
Yeah.
So he doesn't want to take in medicine. So just do
Laser angio.
yeah. So, yeah, so that's not the indication. The indication is you need to take your medications and do laser angioplasty for. Yes, the last question on this thing.
The typical route of implantation for a leadless pacemaker is subclavian pocket plus a venous lead, cephalic vein surgical cut down, direct RV puncture, or a femoral venous catheter based percutaneous delivery.
I'm proud that everybody has got the.
Yeah, so they were listening to you.
Yeah.
These are all trials to see whether they're hungry or not. Exactly. So your comments again. Your last comment on that, please, Dr. Sandeep.
Yeah, and
Femoral
the
vein.
beauty about the leadless pacemaker is it can be deployed through the femoral vein, which is a very common and easy access. You can see that is the capsule pacemaker. You go through the inferior vena cava, right atrium, and just deploy it into the right ventricle. Less than 1 hour procedure. Very simple, and almost no complications.
Yeah, so this is coming from the femoral vein down. You put in this catheter. It's a deflectable catheter. It comes in here. It's hanging by a thread over there. It's got these tentacles which plugs into or screws into the myocardium. We check the parameters. If everything's okay, you have a snipping tool and it snips off. Yeah.
So
The Medtronic people have been kind enough to give us a sample. You can actually see it.
Yeah.
So from the audience perspective, so when would you suggest a leadless pacemaker over a conventional one?
No, we have to select our patients very carefully. If you have a young patient who requires, like a 35-year-old patient who requires a pacemaker, it is better you go for a conventional pacemaker, because this is still in the evolving segment. You need a synchrony between the right atrium and right ventricle for younger patients. There are options in leadless pacing also, but for young patients, it's better to go for a conventional pacing. The other thing is the duration. Once we put this thing inside, it is going to remain inside. So after 10 years, once you're 45 years, what are you going to do? You will have to put in another capsule pacemaker. What about 55 years? Third capsule pacemaker. So that is one problem with the current generation leadless pacemaker. It is rapidly evolving. Now we have durations of 15 years.
Yeah.
Maybe
If the latest one, they're saying it is recapturable.
Yeah.
So yeah, its future is very interesting. So we got some questions on screen. So first one is nice talk, sir.
Thank
Yeah.
you.
Yes.
So how does the future risk due to endothelial injury produced by
Chai, I can see that.
Right.
the endothelial injury produced by the coronary interventions prevented? Example like future atherosclerosis.
Yeah. So I don't think it's a very relevant question there. But yeah.
I mean, it's a difficult question because it is
So
part of it.
risk by coronary intervention causing endothelial injury, that's not a topic. We don't cause endothelial
Yeah.
injury. We prevent endothelial injury.
So we always choose a procedure after assessing risk versus benefit.
So need for anticoagulation leadless pacemaker, Dr. Sandeep.
No, there is no requirement for anticoagulation leadless pacemaker.
So
No
what's
drugs.
the cost of a leadless pacemaker?
The base model now comes at 7 lakhs. There is the highest model that now comes at 12 lakhs. So the issue with pacemaker for the elderly is the cost. Yes, definitely, compared to the conventional pacing.
So we got some fans for Dr. Firoz, our young and dashing cardiologist there.
He's married.
He's married. More thing, and Dr. Firoz is starting to blush right now. Right. Okay, I also got one.
Requirements
Thanks.
for
Are these all these available in Kerala, Calicut? Come on, Sandeep, answer
All
this
these
question.
are available in Aster MIMS.
Calicut, yeah, it's something which we routinely do.
Yeah,
all
it's something we already do.
all the talks, all the stuff which he mentioned on screen are things which are being done routinely. Anticoagulation after TAVI, which VK or NOAX?
Just aspirin.
Aspirin.
No, only aspirin.
How long does the battery of capsule pacemaker last?
Yeah, we just discussed that.
Yeah. So these capsules will remain in heart without any mechanical issues?
There won't be any mechanical issues. It is just holding on to the right ventricular endocardium. So no mechanical issues.
Okay. So how does the indication differ in laser versus orbital?
Complex question for the crowd.
Yeah. In a quick nutshell. So maybe the diameter is something like that.
Yeah, orbital atherectomy is for the calcium modification. Laser is not very good for severe calcium. It is more useful to modify any plaque, even fibrous plaque, to get to the other side. So,
chance of embolization for the micra?
Very low.
Very low.
Almost no.
And what is DCB? Some question was the efficacy and safety of DCB, drug-coated balloons.
It is very safe compared to a stent, definitely. The efficacy, that is one thing I told that the current AHA 2025, there has been a large trial, solution trial. It shows that in most cases, but not in all, the DCB is comparable to stent. So we have to be very judicious.
It's coming up in a very big way because people want to be stentless, metalless. We're doing it very rapidly, using it
I was
day
just
in and day out.
discussing that we are part of a trial.
Yeah, we're part of a trial where we're doing that. What about biovascular scaffolds? Yep, that's an interesting question.
Biovascular scaffold had come up, but due to higher thrombotic rates, they are right now out of the market. So no BVS right now.
DCB cost and duration of stay for DCB, final question.
DCB duration of stay would be lesser than putting in a stent. You can actually maybe even discharge them the same day if there are no complications. And the cost, it is slightly costlier than a stent.
That's it, yes. Fantastic. Thank you very much, Dr. Sandeep. We'll wrap up the session now.
Thank you, sir, for that wonderful presentation.
Thank you, Dr. Feroz. Fantastic.
Thank you, sir. Before we move on to the next session, we'll take a short break for tea. Refreshments are available just outside the auditorium to the left. Please help yourselves and we'll resume shortly.
Yeah, so it's 11 now. We'll reconvene at 11:15. Tea and snacks are on the left over there, on my left. After that, we'll be having our live stations, okay? So I'll just give a quick, on your brochures, you have a number written, a letter written, either A, B, C, or D. All of you will have a digit. So A is here, B is here, C and D are on my right, okay? So after your tea and your snacks, please come back in and come to your station, and we'll start our live sessions hands-on, where we got an arrhythmia station and we got a devices station for us to show. So we will be the first persons who go to A. After the initial time, we'll switch over to B and vice versa. B will switch over to A. C, after there, this thing will switch over to D, and D will switch over to C. So all of you guys, after tea, come down to your respective stations, either A, B, C, or D, as mentioned in your brochure. Thank you, guys. Welcome for tea and snacks. So it might get a little crowded inside. Please bear with it. It's going to be just 5 to 10 minutes. Thank you. sessions arranged for you. So basically one on arrhythmias and one on devices in cardiology, right? So just to get you familiarized with day-to-day activities, what happened in clinical cardiology. So there is an ECG arrhythmia station which sort of brushes up our basics. Once everybody is gathered, we will sort of start. If you're finished with tea and snacks, we will start in, say, a couple of minutes. Okay. Everybody, please gather to your stations A, B, C, and D. जी. Everybody can gather around the stations A, B, C, and D. Those coming in can join up over here at station D.
Check, check, check. Fine.
Yeah. Just deploy this way. Okay, this is how that happens. Right? Ballooning. Yes. Right? Okay. Yeah, deflate it. Classic. That is stand deflate.
Now that you have spent some time at your designated stations, it's time to switch and rotate to the next stations. Please move according to the rotation plan in your folder so you can experience all the activities. Delegates from A, please move to B, and delegates from B, please move to A. Likewise, delegates from D, please move to C. Delegates from C, please move to station D. Thank you.
Time for shifting. A to B and B to A. C to D and D to C.
Yes, we'll do a quick shift.
all the there is a narrow QRS. All waveform QRS are preceded by normal P waves. This sinus tachycardia. And this is a 35-year-old male who presenting to ED with complaints of palpitation and light tenderness. So 1 hour duration. BP is 170. What is the result? There is no doubt that it is narrow QRS tachycardia. Out of narrow QRS, what is the result? Narrow QRS tachycardia can be SVT. In SVT, there are two conditions. AV NRT and AVR. AV NRT, the recircuit of the involving the AV node. Since the AV node is involved, the retrograde P will be very close to the QRS point, which will be manifested as pseudo R wave in V1. You can see a small, this is actually pseudo R wave, okay, and it will be manifested as pseudo S wave in V2-3 area. This is AVNR. And what is the treatment for this patient? If the patient comes to AED, what will you do? This is the second answer I expect. You have to do carotid massage. And how will you do the carotid massage? Below the angle of mandible, you should give firm pressure against the C3, C4 vertebra for about 5 to 10 seconds. And it should be done under monitor. Okay. And there is one more manual which is private, that is Valsalva manual with positional modification. This is the Valsalva manual. Close against the syringe with a of 40 millimeter. Immediately after that, this stage.
Then you take your balloons, ends, whatever. So now he's taking the wire, and now he has to guide it. He can go here, he can go there. So now he wants to go there. If it was a circumflex, he'll go here. But now we want to go to the LED. So he's going there.
If it is not reverting, then go to the medication. What medicine? And what is the dosage? And how will you administer?
Through his balloon. So he takes a balloon. You will demonstrate how the adenosis should be given. From the radial, you have to cross all this. Just show these guys how a balloon looks like. Just show one more piece, one more balloon you have.
Adenosis should be given to a proximal vein, at least cubital vein. One there is external vein that is looking at. Bradycardia following, following adenosis should be done under monitoring only, and this should be facilitated for cardiac massage, and injection atropine should be ready for giving adenosis. Up to 12 milligram can be given. This is some of the ECG. What is the rate? And what is the diagnosis? Narrow or wide? Narrow QR. Is there narrow QR of tachycardia? Ventricular tachycardia, supraventricular tachycardia. Is there a P wave visible? see carefully, you can see some P waves on the T waves. This is a long artery tachycardia. It can be AVRT or atypical AVNRT. The patient's BP is only 70/40. Then the treatment is cardiovascular. Narrow or wide, tachycardia or bradycardia. Is there a P wave? They will not be of the normal morphology. They can be of different morphology. Can you see the PVs? Where is the PV? Normally, the PVs are upright and V2-3 AVL because the depolarization front comes from above. If the depolarization, later depolarization front comes from below, it can look negative. You can see negative PVs in V2-3 AVL at a fast rate, and everything is considered by followed by QRS. This is the ectopic atrial tachycardia. This is 78-year-old gentleman presenting with acute chest discomfort. What is the QRS duration? Narrow QRS. Regular or irregular? Yeah, what is the diagnosis? Okay, only one diagnosis. Irregular, no P waves. Atrial fibrillation. Okay. And how will you treat? There is a new onset, acute onset there. You have to clinically cardiology. If the patient is consistent, you have to use cardiology. Otherwise, can you amiodarone? The dose of amiodarone is 150 milligram per hour 10 minutes, and it can be continued 1 milligram per minute for 6 hours and 0.5 milligram per minute for 18 hours. Or if you can use ibutamoren. Yeah, what is the ECG? Is it a tachybrady, normal or regular, irregular? Is it narrow QRS? Irregular? Is there a P wave or not? You can see the sawtooth appearance. This is called sawtooth appearance. This is the flutter waves. Flutter waves happen at the frequency of 250 to 350. Flutter wave frequency will be 250. It is intermittently there is AV block because it is conducted with variable AV block. That is why it is not regular. If it is conducted with 2:1, ventricular rate will be somewhere around 150. This is CG, narrow QRS, wide QRS, and wide QRS. It is more than 120. QRS, any QRS more than 123 large division is wide QRS. Yeah. Then what is the diagnosis? Wide QRS tachycardia unless otherwise proved, especially in 72 years, take it as VT. Unless otherwise proved. What are the points which suggest that this is a ventricular tachycardia? Can you show the capture? It's not a capture bit, actually, it's a fusion. How do the capture bit and fusion bit happen? In ventricular tachycardia, heart is controlled by the ventricular focus. It will be beating at the rate of 200 beats, around 200. Atria will be controlled by sinus node, which is beating at the rate of 70, 60 or 70. The retrograde impulse will be traveling to the AV node, and it will be blocking the antegrade passage of fluid. At one point of time, some of the impulse will be exposed, and that will capture the ventricular from the control of the ventricular tachycardia. It looks like a sinus beat. That is called capture beat. Sometimes there can be depolarization can be due to sinus beat as well as a combination of ventricular. That results in ventricular fusion. Fusion beat is pathognomonic of AV dissociation. You can see AV dissociation here also. If you carefully, you can see the P waves here. Next P wave here, and this QRS is marching to the P waves. And moreover, you can see if you look at the AVR in patients with wide QRS tachycardia, there is a Verrecki aneurysm. Verrecki criteria is that if there is AVR positive, AVR shows a positive R wave, then it is ventricular tachycardia. because the ventricular activation is happening from below, and the AVR will sense it as a positive. Usually, in supraventricular tachycardia and sinus rhythm, AVR is always negative. Since the focus is coming from below, AVR will be positive. Second criteria is, you can see the V1 morphology. V1 morphology, there is a slurring in the downslope of the S wave. And moreover, the RS pattern is also, R wave is also the suggestive of R wave, R more than R prime. It's also suggestive of ventricular tachycardia. This patient is a white cure of tachycardia, no doubt. What are the points? We already told about AVR criteria. The AVR is positive. And one other point is, this sort of pattern where there is totally monomorphic appearance, monomorphic R wave or monomorphic Q wave, all are positive. This pattern is diagnostic of monomorphic ventricular tachycardia. You can see one fusion beat followed by normal beats. This patient is unstable. What to do? We have cardio. We will learn something regarding cardio and the energy. How many energy you need. When the patient is unstable, start with maximum energy, 200 or 270, whatever is available. And if it is a cardio version, you can monomorphic VT 100 is enough. For atrial flutter, which we have seen earlier, 50 joules is enough. For atrial fibrillation, 120 to 200. In a patient with stable rhythm, when you want to make the cardio version, you have to synchronize the cardio. Otherwise, the R will fall on the T and the patient will degenerate into ventricular fibrillation. This machine will work. Works on the AV, automatic external defibrillator. It makes the work as a pacing. Can use for temporary. It works as a defibrillator from cardio and monitoring. Defibrillation and the right stage is defibrillation. Defibrillation is the maximum recommended defibrillation is the maximum. 270 party and applied there. Then it placed it. If you place it to there, then energy selective, then charging but charging. And this is a 45-year-old me, presenting with palpitation and chest discomfort. What is the diagnosis? It is a narrow or wide? It is a wide curve. But you are when we see angulus observation. For features of ventricular tachycardia. One PV, and other criteria. Okay. There is a beat fusion, which is ventricular tachycardia. AV fusion we can capture with AV dissociation. And moreover, there is a Brugada criteria. There is a R wave in V1. It is suggestive of ventricular tachycardia. There is a S wave. RS distance more than 100 is suggestive of ventricular tachycardia. This is after femoral sheath removal, he has developed some heart rate of 43 and BP of 70. Femoral sheath is removed, introduced for angioplasty, and once you remove that, there will be some pain after removing femoral sheath. So what is the rhythm? What is the heart rate? Rate around 14, auricular, serious proceeding. Sinus bradycardia due to pain. Vasovagal. How do you treat it? IV atropine. How much of IV atropine you give? 0.6 milligram. And you can give fluid source. Okay, what is this ECG? Is it bradycardia or tachycardia? Bradycardia. And what about PV? Bradycardia, what is the rate of brady? It's a complete heart. How do you say that it is a complete heart? You can see more P waves. There is no relation between P and QRS. And the QRS is wide. It indicates that ventricular escape process. That is unstable. 30 rate. Patient will be invariably symptomatic. Patient has to be patient. This ECG is looking like complete heart, but you cannot see P waves, and it is a white QRS. What is it? Imagine a situation where the sinus is not open. Sinus arrest. That is sinus arrest with ventricular escape. Since it is a ventricular escape, the rate is around 30 per minute. In this patient, you have to look for causes of sinus arrest. Hyperkalemia is a hypothermia is a so you look for the causes of sinus arrest and treat it. We have already explained temporary patient. The transfusion space is not available. You can do it on the defibrillator machine. It is a painful procedure. This is a pacemaker. Dual chamber pacemaker. This is CCD. Secondary block, multi-stage. Whenever you see a clustering of beats, you can see 4 beats, 5 beats. The cluster group beats are characteristic of its cycle block. There is a progressive prolongation. This PI, this is the upper limit of PI, 200 milliseconds. Prolong. Next time, prolongation is more prolonged. Then 1 beat is missing. That is orbit cycle. In type 2, there is an after pushing of a beat. And the morbid segment block can be physiological. Healthy people can have it denied. To do a water monitoring, you are supposed to see morbid type 2 block. It is morbid type 1 block. So you don't need to do anything for that morbid type 1 block, especially if it happens during night. What is cause? Anything else you can see in the LED ECG? Whenever you treat orchids, look for QT prolongation. This is the QT interval, 2 to 0. If it is more than half, it is usually prolonged. If it is more than half of the RR interval, it is usually prolonged. Okay. And you can see a ventricular ectopy falling on the T wave, triggering the ventricular tachycardia. Okay. It is rotating around the axis. This one. You can see all the arrhythmia. The last part it is ventricular fibrillation. There is no formed electrical activity. This is process. Okay. The process is generating the ventricular activity. And this is the last ECG. What is the ECG? Base rhythm. You can see two pacing artifacts. There is a dual chamber, A and ventricle, RPC. You finish the ECG, you can see the arrhythmias in the monitor.
ഏത് അരസ്യം അതിന്റെ നമ്പർ നോക്കിയിട്ട് അത് ടൈപ്പ് ചെയ്തിട്ട് എന്താ അടിച്ചാൽ മതിയോ ഈ എക്സാമ്പിൾ കാണിക്കാം 70 ATL ഫിൽറ്ററിലെ
ഷോക്ക് അറിയോ എല്ലാവർക്കും? ഷോക്ക് ചെയ്യുന്നത് എങ്ങനെയാണെന്ന് നമ്മോട് കാണിച്ചു കൊടുക്കും. അല്ലെങ്കിൽ ചെയ്യണമെന്നുണ്ടെങ്കിൽ
നമ്മൾ ഫസ്റ്റ് എനർജി സെലക്ട് ചെയ്യുക. എനർജി നമ്മൾ ഇത് ബൈഫേസിക് ആയത് കാരണം ഏറ്റവും മാക്സിമം ചൂടാണ് നമ്മൾ ഡിഫിബ്രിലേറ്ററിൽ സെലക്ട് ചെയ്യുന്നത്. പിന്നെ ഇതിൽ ഏറ്റവും മാക്സിമം 270 ജൂൾസിൽ നമ്മൾ സെലക്ട് ചെയ്യും. 270 ജൂൾസ് സെലക്ട് ചെയ്തിട്ട് നമ്മൾ ഈസിക്കാ ചെയ്യുന്നത് വന്ന് നമ്മൾ പേഷ്യൻ്റ് നിലവാണ്. അപ്പോൾ നമുക്ക് ഒരു പക്ഷേ നമുക്ക് ഡിഫിബ്രിലേറ്റർ ഉണ്ടാവും, ഒരു അറേഞ്ച് ചെയ്യണം. അതിന് നമ്മൾ പേഷ്യൻ്റ് ലൈഫ് സേവ് ചെയ്യാൻ നമ്മൾ എന്ത് ചെയ്യാം, പൾസ് ഉണ്ടോ എന്ന് നോക്കിയിട്ട് CPR നമ്മൾ സ്റ്റാർട്ട് ചെയ്യാം. സ്റ്റാർട്ട് ചെയ്ത് ഒരു മിഷൻ വന്നു. അപ്പോൾ നമ്മൾ ലീഡ്സ് എല്ലാം നമ്മൾ കണക്ട് ചെയ്തിട്ട് നമ്മൾ പേഷ്യൻ്റ് ഷോക്ക് ചെയ്യാൻ പോകണം, ഡിഫിബ്രിലേറ്റ് ചെയ്യാൻ പോകണം. കാർഡിയോവേറ്റ് ഡിഫിബ്രിലേറ്റ് ചെയ്യും. അപ്പോൾ നമ്മൾ മാക്സിമം ഫോഴ്സ് സെലക്ട് ചെയ്തു. നമ്മുടെ ജെല്ല് ഇതിൽ അപ്ലൈ ചെയ്തു. നമുക്ക് ഒന്ന് നമ്മൾ ഒരു നമ്മൾ കേരളത്തിൽ നമ്മൾ അപ്ലൈ ചെയ്തു. നമ്മളിവിടെ സ്റ്റാർട്ട് ചെയ്തു. നമ്മൾ ഡെമോ ഞാൻ കാണിച്ചു തരാം. ഇത് റിതമാണ്. നമ്മൾ ചാർജ് ചെയ്യുമ്പോൾ ചാർജ് ഏറ്റവും മാക്സിമം ഇതിൽ 360 ആണ്. ഇത് ബൈഫേസ് അല്ല, ഇത് നമ്മൾ ജസ്റ്റ് ഡെമോ പർപ്പസിന് വേണ്ടി വരുന്നത്. ഏറ്റവും മാക്സിമം ആയത് നമ്മൾ 360. അപ്പോൾ നമ്മൾ ചാർജ് അതായത് നമ്മളൊരു കാർഡിയക് അറസ്റ്റ് വന്നു. നമ്മൾ പ്രകാരമാണ്. അപ്പോൾ നമ്മൾ ഇനീഷ്യലി നമ്മൾ ഈ റിതം കണ്ട് നമ്മൾ CPR സ്റ്റാർട്ട്. അപ്പോൾ CPR അവിടെ കൊടുത്തു. നമ്മൾ 2 മിനിറ്റേക്ക് നമ്മൾ സ്റ്റോപ്പ് ചെയ്യും. എന്നിട്ട് നമ്മൾ റിതം അനലൈസ്. എന്നിട്ട് നമ്മൾ BP ആണ് അല്ലെങ്കിൽ PE പൾസ് ഏത് റിതമാണ് അസിസ്റ്റാണോ അതനുസരിച്ച് നമ്മൾ തീരുമാനങ്ങൾ മുന്നോട്ട് പോകും. നമ്മൾ സ്റ്റോപ്പ് ചെയ്യേണ്ട റിതങ്ങളാണെങ്കിൽ ഈ വെൻട്രിക്കുലർ ഫിബ്രിലേഷനും വെൻട്രിക്കുലർ തടിയുവാണെന്നുണ്ടെങ്കിൽ നമ്മൾ എന്ത് ചെയ്യും? ഡിഫിബ്രിലേറ്റ് ചെയ്യും. ദെൻ CPR സ്റ്റാർട്ട്. ദെൻ 2 മിനിറ്റ് റിതം നോക്കും. അങ്ങനെയാണ് നമ്മളൊരു മാക്സിമം ഒരു 6 സൈക്കിൾ വരെ നമ്മൾ നോക്കും. 30-24 മിനിറ്റ് നമ്മൾ. അപ്പോൾ അതിൻ്റെ ഇടയ്ക്ക് നമ്മൾ റൂട്ട് കിട്ടി മറ്റുള്ള കാര്യങ്ങളിലേക്ക് കൊണ്ടുപോകും. നമ്മൾ കാർഡിയോവേഷൻ എന്ന് പറഞ്ഞാൽ ഇതിനകത്ത് നമ്മുടെ എല്ലാ മെഷീനകത്ത് സിങ്കർണൈസേഷൻ എല്ലാവരും. അപ്പം നമ്മൾ ഇപ്പോൾ നേരത്തെ റെക്കമെൻഡ് ചെയ്ത പ്രകാരമുള്ള ട്യൂബ്സ്, അത് പറഞ്ഞു. അപ്പോൾ ആ നമ്മൾ AF ആണെന്നുണ്ടെങ്കിൽ നമ്മൾ എല്ലാ AFിനും നമ്മൾ എന്ത് ചെയ്തില്ല? കാർഡിയോവേഷൻ അൺസ്റ്റേബിൾ ആണ്, ഹൈപ്പോടെൻഷനിലാണ്. അങ്ങനെ നമ്മൾ മെഡിക്കൽ കാർഡിയോവേഷൻ നോക്കും. എന്നിട്ട് കാര്യമില്ലെന്ന് പറഞ്ഞാൽ അൺസ്റ്റേബിൾ ആകാതെ നമ്മൾ മെഡിക്കൽ കാർഡിയോവേഷനിലേക്ക് പോകും. അപ്പോൾ കാർഡിയോവേഷനിലേക്ക് നമ്മൾ ഫസ്റ്റ് നമുക്കിവിടെ സിങ്ക് ബട്ടൺ എനർജി സെലക്ട് ചെയ്തു. സിങ്ക് ബട്ടൺ ഓൺ ചെയ്തു. നമ്മൾ എനർജി സെലക്ട് ചെയ്തു. ചാർജ് ചെയ്തു. ഇത് നമ്മൾ ഡിഫിബ്രിലേഷൻ നമ്മൾ പ്രിഫറബിളി നമ്മൾ വെൻഡ വിഡാസോൺ അതായത് നമ്മൾ റെസ്പിറേറ്ററി പ്രോബ്ലം നമ്മൾ 4 വിഡാസോൺ കൊടുക്കുക. പിന്നെ വെൻഡൻ്റെ 25 മാക്സിമം 100. ദെൻ വിറ്റാമിൻ അപ്പോൾ കംപ്ലീറ്റ്ലി സെലക്ട് ആയി മാത്രം ചെയ്യാൻ പറ്റും. എക്സാം പോകാൻ മാത്രം ലൈവായിട്ടുള്ള പേഷ്യൻ്റ് അപ്പം നമ്മൾ കൃത്യമായി കൺസൾട്ട് ചെയ്യും. അപ്പം നമ്മൾ ഈ കാർഡിയോളജി ചെയ്യുമ്പോൾ നമ്മൾ എപ്പം വല്ല പേഷ്യൻ്റ് അത് അൺസ്റ്റേബിളിലേക്ക് പോകുമ്പോൾ നമ്മൾ സ്റ്റോപ്പ് ചെയ്യും. നമ്മൾ വ്യത്യാസം ഡിഫിബ്രിലേഷൻ പേഷ്യൻ്റ് കൊടുത്താൽ അപ്പം പക്ഷേ കാർഡിയോവേഷൻ എല്ലാവർക്കും പറ്റുന്ന ഒരു മിസ്റ്റേക്കാണ്. ഡിഫിബ്രിലേഷൻ ചെയ്യുന്നതുപോലെ തന്നെ നമ്മൾ കാർഡിയോവേഷൻ ചെയ്യാൻ പാടില്ല. ആ പാടില്ല. 30 സെക്കൻഡ് നമ്മൾ സിങ്കർണൈസ് ചെയ്യുന്ന ആർവൈസിനാണ്
Since the hands-on live sessions are coming to an end, we'll be shortly starting our next session. Hope you all had an engaging and informative time at the hands-on live stations. I'm sure it was a great learning experience for you all. Before we move on to our next session, please be seated.
Hello. Yeah, so I think we guys will all start recollecting back to our Dr. Firoz is very aggressively explaining arrhythmias in station D. He's not leaving the crowd. Yeah, so I think we can all gather ourselves back for the wrap-up session of today's event. I hope all of you guys had some insights into arrhythmias and devices in structural and interventional cardiology. And very soon we will restart today's session. If everybody can get seated, I think we would start. Again, a lot of aggressive arrhythmia going on in station D by Dr. Sadiq and Dion.
Now, moving on to the next session, a line we have all heard in the ER. Doctor, there is some ST elevation in this patient's ECG. Should I thrombolyze?
To clarify these crossroads we often face, we invite Dr. Sudeep Koshi Kurian onto the stage. Over to you, sir.
Check. Good afternoon. So I hope you enjoyed the roller coaster ride in cardiology. Now let's get to some raw emotions. Why this talk? Down. Okay. It's not coming. Okay. It's not going. No. Next is it's not going forward. No. Next one. Not going. Yeah. Will it go? Okay. Some raw emotions. We all feel that, patients don't recognize a coronary heart disease, a heart attack. They have all these problems are coming together. So we feel bad that the patients have not diagnosed the symptoms correctly. But even more symptomatic, even more problem is there when we as doctors, as junior doctors, physicians and cardiologists, we don't recognize a chest pain. So here there are two scenes. I don't know. These same patients, actually, the family I met around 10 days ago. A person who was serving food in a marriage function, he had some discomfort. He went to the doctor. He thought it was gas, and then he went back to the function and he collapsed. And I met the family. It was a very nice doctor, but he didn't take an ECG. The second thing is a 25-year-old patient, a man. He had some pain and he had some ECG changes of ST elevation. And he was actually, he had to be referred to a medical college. And this lady, who's a mother, she had a heart attack. And the guy turned out to be normal. So in this world where we see ST elevation of all types in the ECGs, do we recognize the correct ST elevation as MI or the other things, or the mimics? That's a question here. Next, yeah. So as a junior doctor in an emergency medicine department, when you see ST elevation and you have chest pain, you are panicking because you don't know whether this is true ST elevation. As a physician, you have little more sense over this ECGs and all the things. And finally, the buck stops with the cardiologist. Like President Truman said, he had a thing on his table that the buck stops here. So the cardiologist cannot pass the buck anymore. So today's, why it's not moving forward? Yeah. Yeah. Okay. So today's talk, why talk about this is because the identification of true ACS, the obvious cause, the obvious ECG, and the subtle ECGs. And if it is ACS, what are the sinister ECGs, like left main or proximal LAD or something with conduction abnormalities, and imposters and the mimics of ACS. This a basic of the evaluation of acute MI, a normal ECG, it will go on to hyperacute T waves in minutes and ST elevation in minutes or hours, and then the T will invert, having T inversions and Q waves in hours, and then finally in days there is a loss of R wave and T inversions and Q waves in days. This is a normal progression of a STEMI. A 65-year-old with chest pain and hypotension, you can see the ECGs. What is obvious here is there is an ST elevation in AVR and then ST depression in multiple leads, like lead 1, 2, V4 to V6. So what do you think this is? So a significant LMCA disease or severe triple vessel disease. There is widespread horizontal ST depression, most prominent leads 1, 2 and V4 to V6, and ST elevation in AVR more than 1 millimeter, and ST elevation in AVR is more than V1. These are the features. This is the ominous sign. 54-year-old man, chest pain lasting for 10 minutes, present to the ED, pain-free at present. What do you see in the ECG? The first ECG you can see a biphasic T wave in V1 to V3. And half an hour later, on shifting ICU, patient had profuse sweating and chest pain. You can see ST elevation in V1 to V4. This is what is called the Wellens syndrome. We have two types of Wellens. biphasic T inversion in anterior leads, and deep T inversions in anterior leads. These two can happen in valence. A word of caution here, all T wave inversions are not valence. The T wave inversion has to be more than 1 millimeter and it has to be in 2 continuous leads for T inversion to be significant. Valence syndrome is a highly specific for critical stenosis of left anterior-descending artery. May be pain-free by the time ECG is taken, and the cardiac enzymes may or may not be raised. This has a high risk for extensive anterior MI within the next even hours, days, or even weeks. So you can't miss this ECG. You can see that, please go on. You can see the proximal LAD occlusion. You can see that the artery is so huge, it supplies 65% of the myocardium. So if that goes, that is an important cause of cardiac arrest. 45-year-old doctor with chest pain. I had a very senior physician a few days back. He has diagnosed so many cases, but his own case he couldn't diagnose. He thought was, we live in a state of denial most of the times. Okay, please go back. Please go back. You can see this pattern of ECG. This is also a sign of proximal LAD occlusion, the Deventer ST wave complex. You can see that ST coving and the tall T waves in V1 to V3. This is the Deventer sign. 32-year-old with typical crushing chest pain. You can see the ST elevation in 1, AVL, and V2 to V6. This is anterolateral STEMI, an extensive anterolateral STEMI. Please go forward. This is a 50-year-old smoker with diaphoresis and chest heaviness, anterior or inferior STEMI. What is it, anterior or inferior STEMI? You have ST elevation in 2, 3 AVF as well as the chest leads. What do you think? Correct. Go. Go forward, please. Go forward. Yeah. It could be a wrap around LAD. That's one of the diagnoses. Next. So these are the diagnosis when you see a elevation in inferior anterior leads, distal LAD occlusion or wrap around LAD or a multivessel CAD. You have a right coronary artery involved earlier, and LAD is collateralizing the right side, and also isolated disease of a very dominant LAD. This is another ECG with an ominous sign, anterior STEMI, QRBBB. When you have a QRBBB pattern like this, it is a proximal LAD occlusion and it carries grave prognosis. I think you are going backward. Please go forward. Yeah, so this is just a recap of the real STEMI. Septal is V1 to V2, anterior V2 to V5, anteroseptal V1 to V4, anterolateral 1 AVL V3 to V6, and extensive anterior which involves 1 AVL V2 to V6. Next. So this is just, we all know this. I'm not going too much into that. 60-year-old with profuse sweating. So inferior wall STEMI, it's a very, you won't have much damage of the myocardium, but you'll have conduction defects, and if you don't reach the hospital quickly, you can have conduction abnormalities. This is an inferior STEMI, and please go forward. On reaching the ICU, you can see that there is a complete heart block with a broad complex escape rate, and this patient needs urgent attention or revascularization. What else to look for? So now we have seen the obvious signs. Now look for the subtle signs. RV infarction. You can have an ST elevation in V4R, subtle ST elevation in V1, and usually ST elevation lead 3 is more than 2. This is how you identify an RV infarction associated with inferior wall. What does it look for? What does this ECG show? This is a subtle sign. It is not very subtle, but you should not miss this. You have an inferior wall MI. Please go back. And ST depression, down sloping ST depression in V1 to V3. Next slide. V1 to V3 horizontal depression with tall, broad or upright waves is a posterior wall MI. What else? Please go forward. Yeah, inferior STEMI, 2, 3 AVF. Lateral, if it involves 1 AVL and V5, V6. V7, V8, V9 posterior is a posterior STEMI. And this is another algorithm showing where the localization of MI. Will not go much into that. Next slide. ECG predictors of reperfusion. Sometimes reperfusion can occur in your OPD also, right? You didn't have to thrombolize. ST segment resolution, T wave inversion, AVR and polymorphic VT also can occur during reperfusion. This T wave inversion is very important because in acute pericarditis you can have T wave inversion only after days, not like STEMI where it occurs concurrently. Next. And what are the mimics? We have pericarditis, benign early repolarizations, LVH, LBBB, Takotsubo, Brugada, electrolyte abnormalities like hyperkalemia. Yeah, in pericarditis, we can have diffuse ST elevation. It is not regional. You can have diffuse ST elevation and PR segment depression. PR segment depression is very common, and patient can have pleuritic chest pain and no reciprocal changes. This is very important. There's no reciprocal changes. Then there is another thing called the spodic sign. That is a downsloping TP segment. You can see that it is a downsloping TP segment. It's called the spodic sign. Okay. So how do you compare benign early repolarization and acute pericarditis? I'll come later. Next slide. And also, an important thing in pericarditis is this ST-T wave ratio. If it is more than 0.25, it is consistent with pericarditis. You can see this ratio. Whereas in benign repolarization, this T wave will be taller, and this ratio will be less than 0.25. So this is an important distinction between benign early repolarization and pericarditis. So this is one of the signs, and this is what I've said about the spodic sign. Please go forward. The downsloping TP segment. Next one. Early repolarization. This is one ECG which we see very commonly in the OPD, especially in a younger person. It usually doesn't happen beyond 50 years. Young and healthy, there is a J point notching you can see, and a concave ST elevation, and it's a stable pattern. It doesn't evolve, it's a stable pattern, and typically the patient won't have typical symptoms. So this is one of the patients I showed in the beginning who was sent to the medical college, and the mother had a heart attack. So we can't go both ways. We have to diagnose. It's a very tough call. It's very difficult, but we have to do it. This is what I said before. In benign early repolarization, the ST-T wave ratio is less than 0.25. You can see that. Now, the ST segment height is 1, T wave height is 6, and the ratio is 0.6, which is less than 0.25. So this is a distinction between, one of the ways we can distinguish between benign early repolarization and acute pericarditis. Next. So this is in a table, the differentiating features between benign early repolarization and pericarditis. The ST elevation is limited to the precordial leads, mostly in BER. No PR depression, prominent T wave amplitude, and ST-T wave ratio is less than 0.25, and there's a fish hook appearance in B4. Pericarditis, generalized ST elevation, PR depression, normal T wave amplitude, the ratio is more than 0.25. Okay, next slide. Another common thing is LVH. When you have a left ventricular hypertrophy, it will give the appearance of a ST elevation. So very commonly, you can see the strain pattern. And there is something called the ST-T mismatch. When you have an MI in LVH, the lateral leads, V5, V6, should have a strain, ST depression, strain pattern. But if you see an ST elevation in those leads, it is typical of ischemia. Whereas, and also, wherever you have an ST depression, if you have a prominent ST depression, more than 2, deeper ST depression, then also that might indicate a ongoing ischemia. Similarly, the T wave inversion is also important. The T should be upright in the precordial leads. But if there is a T inversion there, so there is a ST-T mismatch, then also that is more likely to be ischemia. Okay, or a new T wave inversion. For example, there's something called pseudo-normalization also. So you can have a T inversion in a patient who, the former ECG you'll have a T inversion. But then when you take a new ECG, the T will be normalized. That's pseudo-normalization. That is also suggestive of ischemia. So in a patient with left ventricular hypertrophy, these are the features where you identify ischemia. LBBB with MI, this you face very often. You can have, it's okay. Next slides. So there was an original Garbosa criteria. Now we have the modified Smith-Garbosa criteria. You have a concordant ST segment elevation greater than 1 millimeter in a lead where you have in the same direction as of the complex. So this is 1 millimeter. And then you have a concordant ST depression more than 1. That is also in the complex, the direction of the QRS complex. So that is also very important thing. 5 points for this, 3 points for that, and a discordant ST elevation, segment elevation, that is also 2 points. So if you have 3, it is more suggestive of an MI in LBBB. And now the modified Garbosa criteria, it is just not ST segment elevation because that can vary. Here they take a ratio with ST and S ratio more than 25%. So that is more sensitive. So these are the 3 parts of modified Garbosa's criteria. Next. What is Takotsubo's cardiomyopathy? So, it's otherwise called the broken heart syndrome. They have a history of emotional or physical stress. They have an apical ballooning on the echocardiogram. If you don't have access to the echocardiogram, you can't diagnose it. And ST segment elevation can be there. It can present with all the features of a normal ST segment elevation. The only difference will be this apical ballooning, okay? And also on coronary angiogram, it will be normal. So it's very difficult to diagnose, but the history will be there. Usually in women, middle-aged women, you see, especially after death of someone or a significant illness or theft in the house or fire in the house, that's what we see usually. So you can see that echo, the normal heart, and the Takotsubo heart, you can see that like an octopus trap. The apex is ballooned out. Okay, the ECGs will show ST elevation, and then T-wave inversion can go the same way. The famous Brugada pattern. So there are 3 types of Brugada: V1 to V3 coved ST elevation in a patient with RBBB also. It's often triggered by fever. So it is very commonly seen, not very commonly, but the Brugada syndrome is not very common. Brugada pattern per se is not very dangerous, but Brugada syndrome can be dangerous with symptoms of syncope and all those things. Next one. So these are the 3 patterns of Brugada. Type 1 is an ST coving, okay, with a T inversion. Type 2 is a saddleback. Initial ST elevation, then a downsloping, and then towards the end again ST elevation. And type 3, you have the same pattern, but the ST elevation is not much. It is less, it's 1 millimeter something. Okay, so these are the 3 types of Brugada. Next. Hyperkalemia, I'm not going into the ECG changes in the different stages of hyperkalemia, but you can look at the T wave. It is sharp pointed T waves, peak T waves and widened QRS, and a sine wave tendency. When you have a hyperkalemia, very high potassium levels, it goes into sine wave tendency. So this is the important, the peak tower, it's like Eiffel Tower. Next one. You can see the difference, hyperkalemia, it's a peaked increased height without increase in area. Whereas in the hyperacute, you have an increased area under the curve. See the difference, you remember the structures, you will know the difference. Next. Okay, a comparison between the T waves. The hyperkalemia is the Eiffel Tower. The hyperacute wave is like a broad-based. And then in benign early repolarization, you can have that fish hook sign. There is a notch at the end of QRS. Next. There's something called ventricular aneurysm. Post-MI ventricular aneurysm can also have a persistent ST elevation. So you can compare with the old ECG. So any patient with any changes in ECG, please ask for the old ECG. ST elevations can be concave or complex. They are static and do not change. They don't evolve. And sometimes the patient won't have pain also because this is a previous MI. It persists for more than 2 weeks after STEMI. The STEMI evolves, right? I have shown you the initial evolution. They do not have ST reciprocal depressions, and you can see pathological Q waves in that anterior leads and flat to negative T waves. So in ventricular aneurysm, they usually have a history of a old anterior MI. Okay, next. Prince metals angina, transient ST elevation, and relief by nitrate. And you can see that sometimes, but that's also unless you do an angiogram, you can't say for sure it's the same. Next one. So this is just a table to show what I've discussed so far. STEMI, you have a convex tombstone ST elevation, hyperacute T waves, and an evolution of the T wave. And you can have T wave and ST elevation, T wave inversion and ST elevation together. And then you have Q waves. And it's territorial ST elevation. PR segment is normal. There are reciprocal changes. And the clues are new onset LBBB, chest pain, evolving changes. The clinical clues are the best. Pericarditis, you have diffuse concave ST elevation. The sporadic sign and PR segment is depressed, except in AVR where PR segment is elevated. And then widespread ST elevation. It is not regional. And no Q waves. And then, of course, you have the symptoms of pericarditis. Okay, early repolarization, I've showed J-point notch, the fishhook sign, usually V2 to V5. And it is PR segment is normal, reciprocal changes are absent, benign in young adults. And if you ask the patient to walk, if the heart rate increases, usually it disappears. Okay, and the Brugada I've said, coved or saddleback with RBB pattern, V1 to V3, normal PR segment, no reciprocal changes. Okay, only the type 1 has an arrhythmic risk, especially when the patient has Brugada syndrome, the symptoms. And Takatsubo, I said, you can't actually differentiate unless you do the angiogram. And you have to, for all reasons, you have to treat it as acute coronary syndrome until you see the angiogram. Next one. The summary, which is very important. When in doubt, always take an ECG. Never miss the obvious. The person I've told in the beginning, actually, ECG was not taken. If ECG was taken, obviously, probably you would have seen an anti-wall MI or something. So never, when in doubt, always take an ECG. It is worth it because most of the people come and tell you that they have gas problem. See, I, as a resident and as a medical student, then as a physician, then as a cardiologist, what I used to do is I used to go back to the patients who had MI and ask them about how the pain was. Every patient, even now I do it, even if it's not my patient, he had an MI, I said, how did you get that pain? Because that repertoire of information has to get into your head so that you won't miss this. Because you have to take an ECG. That is one thing. So history is so important. Look for subtle ones and the ominous ones. The subtle ECGs are the RV infarction, okay, and all those, posterior wall MI, all those subtle ones. And the ominous ones, the Wellens and the Devinters and the QRBBs, I mean, all those things. Age, gender is very important. So the initial photograph showed a 25-year-old young man being taken in an ambulance. So at the age of 25, it's very unlikely. I had few patients during COVID times coming with thrombotic occlusion, but usually it's unlikely. So age is also important. Below 30, less likely. Female, less likely below. So age and gender is important. And of course, the symptoms. The symptoms, as I've said, you have to ask and ask and ask. Never stop asking for symptoms. How much ever high you grow, you never stop asking the history. Any patient, you talk to a patient and then you'll know how all they present, what all they speak. Regional, some areas they say Erichal, some areas they say Kadachal, some areas they say some pressure. Okay, so don't go by textbook science. You have to understand regionally how they say this angina. And then comorbidities and family history, another important thing. The comorbidities are so important. A diabetic for 10 years, more likely. Okay, somebody who has no comorbidities, less likely. Family history, history of emotion, trauma, and critical illness, important, especially in young women with Takashimo's cardiomyopathy. And the ECG, territorial versus global. I've mentioned territorial is MI, global can be pericarditis, benign repolarization. Reciprocal changes, very important in STEMI, reciprocal changes. If you see the reciprocal changes, you go more towards STEMI. Subtle variations. Dynamic changes, that's the importance of taking ECGs after half an hour. Don't leave the patient. Take ECGs after half an hour, you can see dynamic changes. STEMI equivalents like posterior wall, RV, Wellens, Devinters, and new onset LBBB. And also repeat ECG, especially if symptoms are sensitive. One ECG is not enough. Okay, and finally troponins. If you have access to troponins, you should not use it indiscriminately. but reasonably, in order not to miss an MI, you can use droplets. So this is what I wanted to, tell about to the whole with the ischemia and its mimics. Thank you very much.
Thank you, sir, for that very informative talk. I would like to invite Dr. Anwar, sir, to moderate the session, please.
Thank you, Sudeep, for that fantastic run through one of the most important things in clinical cardiology. Right. We'll have some questions, Dr. Anwar.
First question. Pericarditis typically differs from STEMI because ST elevation is focal and localized. ST elevation is diffuse with PR depression. There is deep Q wave formation early. Reciprocal ST depression is common.
Right, Dr. Sudeep, I think everybody has caught on to what you said. So the trend is towards being diffuse ST elevation, PR. Any thoughts which you'd like to say?
Yeah, diffuse ST elevation and PR depression is the most important thing, along with the other signs which I've told before, like the spottic sign is important, and the history. If you read it alongside together, it's important.
So I've got an ECG on the screen there for you. So, I mean, although one learns a lot of theory about, when an ST elevation comes in front of you, Dr. Sudeep, it is really a challenge.
It's a challenge.
Yes, it is a challenge. So look at that, that guy standing looking at lead 1, lead 2. It looks a little scary at first. We come across this very routinely, but then you see the ST elevation and you want to send a troponin, or you want to send for. We've had patients, if you remember, a decade back, who had thrombolized for this, and can be catastrophic because a pericarditis.
You're right. There was a patient who was a bus conductor who was thrombolized, and he had a teratoma with a
and he had massive hemorrhagic effusion because
he survived.
Because the pericardium is the point of source of the inflammation. It's already inflamed. You thrombolize the patient, it goes into a cardiac tamponade because of blood within the pericardium. So although you see these ST elevations, there's a point of concern over here, is that when you see the ST elevation, you don't get scared. Just try to sit and look at it. So like what Dr. Sudeep said, I think the lack of focal distribution. So you look at one AVL, that's there. You look at 2-3 AVF, that's also something's happening. Something is happening in the anterior leads also. And then something which we are not very trained to look at. Dr. Sudeep, if you could show them the PR depression, is something which our eyes don't actually go in. Look at that PR actually hanging down, it's like a sock. So that PR depression, you can see that in the TP segment just prior to that. That's how it's measured. So when you see that PR depression, I think that's a big point to catch pericarditis. And then look for the pericardial rub. Look at the clinical scenario. Very, very often that these kind of patients get thrombolized, heparinized, and then creates a big mess. We have the luxury of actually doing an echocardiogram and seeing that pericardial effusion or a little bit cardiac effusion, but then you have to have that deep sense of index of clinical suspicion. So that's how the PR depression looks like, and that's that concave upward ST elevation which Dr. Sudeep mentioned. All right.
Next question. Which condition most commonly causes ST elevation restricted to V1 to V3 with a RBB pattern, like pattern? Hypercalcemia, Brugada syndrome, hypokalemia, pericarditis.
Yeah, so again, sort of easy, Dr. Sudeep.
Yep.
Please take it.
Brugada syndrome is the one which is dangerous, and a lot of people, youngsters, have Brugada pattern on ECG, and the one of more concern is the type 1 Brugada. Actually, if it is actually precipitated by fever. Sometimes you can see it during fever.
It's on the screen.
Yeah. So there's a coved ST elevation on type 1, and type 2 you can have a saddleback, and type 3 you don't have that much ST elevation, but it's the same pattern as type 2.
It is a little bit of a challenge once you see an asymptomatic guy coming with a Brugada pattern. There are some schools of thought where you can do certain challenges and all, the flakenite challenge and Ajbali challenge. But then most of our experiences, they'll do well. If such a patient comes with a loss of consciousness, that
Then
becomes sort of a worry.
that's important.
That's important worry. So to recognize a patient retrospectively with this who has a loss of consciousness, that becomes really important for ventricular tachyarrhythmias.
Which ECG feature is most suggestive of Takotsubo cardiomyopathy rather than STEMI? ST elevation limited strictly to LAD territory. ST elevation with widespread deep T wave inversion across multiple coronary territories. Reciprocal ST depression in inferior leads. New pathological Q waves within the first step.
Yeah, so I'm sorry, half of it is not very clear. But yeah, so some people thought that Takotsubo, it's a little bit of a gray zone there, but the correct answer is the second one with a little bit more widespread.
It is not strictly limited to LAD territory. That's the thing. It can be LAD territory, but it is not strictly limited to LAD territory. It can be widespread. Usually widespread.
So the echocardiographic abnormalities are sort of to the LAD territory.
That is the thing.
Apical ballooning, yeah. So a little bit widespread there for Takotsubo. But then again, the history is very dramatic usually.
Correct.
Dr. Sudeep has a lot of patients who are stressed out.
10, 15 patients.
Yeah, stressed out, and so this is something what a Takotsubo might look like. A little bit widespread, very much looking like an anterior wall MI. And actually, I would say, Sudeep, it's a diagnosis of exclusion.
It's a diagnosis of exclusion. You have to do an angiogram. Otherwise
You have to do an angiogram. You cannot upfront say this is a Takotsubo. You could tell the bystanders and the relatives that I am thinking of a stress cardiomyopathy, but it is a diagnosis of exclusion, and you have to exclude by after you see a normal angiogram, then you label it Takotsubo cardiomyopathy. What do you say, Dr. Anwar?
Yes.
Exactly. Right. Okay. So most of us got the drift of what is discussed in terms of ECG STEMI mimics. The more I was just chatting with a few doctors today, and more people want to learn about ECGs. We've created a group in the WhatsApp. People who have doubts, we're free to discuss in the days, months, and years to come. So let's handle some questions.
Sir, myocardial bridging can cause ECG change, any ECG change.
No, I mean, it is not very non-specific. You need not have any ECG changes as say in myocardial bridging.
So just
That-
to
that's angiographic
explain what
diagnosis.
is bridging.
Bridging is when the left angiodescending artery, and mostly left angiodescending artery, goes through the muscle. So usually the myocardial perfusion happens during diastole. Usually it happens during diastole. So during systole, it actually compresses the left angiodescending artery because it goes through it has an intramyocardial course. So usually there's no problem because diastolic perfusion happens, for coronaries, right? So that's not a problem.
Yeah, so bridges have been studied for a long time. Generally, they don't do much harm. Very rarely, with very hyperactive left ventricular hypertrophy, they can squeeze up the coronaries in systole. But yeah, not any ECG changes as such, no. Okay, LVH with ischemia. So they want to know how to diagnose ischemia in a patient with
So
LVH.
actually, I was actually mentioning about the STT, the pattern. No, in a patient where you have ST depression, if you have an ST elevation, for example, V5, V6, then it's suggestive of ischemia. And if you have a more significant ST depression, also it's suggestive of ischemia. When you have a deep S wave, where you should have an upright T wave, and there if you have an ST depression of an inverted T wave, then it's more suggestive. So these are the different areas, and also a pseudo normalization of the T wave. I mentioned this during the talk, right? So all these features can show an ischemia in a patient in a ECG with LVH.
Two named signs, South African flag sign and Aster pattern.
Salman had you had put that. I forgot to put that slide.
Yeah. So
You
the
have-
South
you have a-
African. No, I don't have the ECG with me right now. Yeah, the South African flag is a D1 occlusion, a diagonal occlusion, which looks like, I could fetch it out for you, but it's basically a high lateral occlusion, so which looks like the South African flag on a 12-lead ECG. I think you can Google it up and you'll understand how the South African flag looks like. Early repolarization, should we follow up?
early repolarization, actually it's like benign, but nowadays they have said that if you have a horizontal ST, after this concave is ST elevation, a horizontal ST is more significant, could be problematic. That's what they say in some studies. Otherwise, it's not very harmful. And usually, as I've told you, if you can make the patient walk or something, or once his heart rate increases, it disappears, and usually it disappears after 50 years. So usually it's not a problem.
Yeah, so previously it used to be called BER, benign early repolarization. It is no longer called that because it's, some people say it's not actually benign. Some reports of tendency for ventricular tachyarrhythmias, but at our level, I think we can just understand that this abnormality happens and this can cause concave ST elevation. When you see LBBB for the first time, how can you say it's new onset?
You cannot say it is new onset unless you have an old ECG, but I have mentioned that criteria in LBBB, how you diagnose MI. You can't say it is new onset, okay, unless you have an old ECG. But based on the Garbosa's criteria, you can, say whether it is MI or not.
So when you have an ECG which is showing LBB, your patient is coming to you first time, you do not have anything else, the patient is having chest pain. So you are wanting to know whether it's a new onset LBB. That's the question which they want to say. You have no methods of saying that. You are going to write newly detected LBBB because the patient's files, records, nothing shows anything. You're saying it's an LBBB, probably new onset, but it's newly detected. You are detecting for the first time. Baki, you have to use your clinical judgment, the signs, the echocardiogram, the troponin to understand if it's a coronary ischemia.
Correct.
Correct?
Yeah.
That's it, yeah. And
is there any advantage in doing angioplasty on
Angioplasty?
on day one?
Which one? Where is it?
the last one.
Definitely. I mean, time is muscle. So day one, maybe the golden hour, the first hour itself. So there is no doubt about it. As soon as possible, especially in such major tertiaries like left ventricular artery and any acute coronary, it's best to do early. There's no doubt about it. Fitness brand watches. Okay, so to detect AF or an arrhythmia like that, it's okay. But a VT, I mean, you won't survive. I mean, so I usually it is used for detecting AF. Right, Salman?
So I think the question was for how good is it for coronary?
Coronary, I don't think so.
No.
It's not good.
No, it's not. It's a box thing that it's not used as. It's not a substitute for an ECG because most of them have got only a single lead. It's good for rhythm analysis, and all of them are well developed for atrial fibrillation delineation. So, but no, it's not a hoax. They're all FDA approved for Apple Watch, Alive Core, and even the Samsung latest series are approved for atrial fibrillation detection. You cannot use it for MI. If you see ST elevation on the thing, you can probably run and take a 12-lead ECG. Some love for you. Be happy. Fantastic.
Yeah.
And
when trop is elevated, is it always coronary artery disease? If not, should we repeat trop test?
No, when trop is, there is some myocardial injury. Okay, you have a myopericarditis, you can have trop raise in a pericarditis, myopericarditis. You can have trop injury, a trop raise in what do you call Takatsubo. So, what happened?
No, it's
Okay.
there are some people playing around with it. So he's got distracted. He forgot what he was saying.
Okay.
He's talking something.
Yeah, okay.
Tropy, yeah, that's all the same. Yes, it's not important. Whichever lab, whatever you have, that's okay. If you don't have last question, we'll wrap up. If you don't have a primary angioplasty option, is thrombolysis good? Any difference between tenecteplase and STK?
Yeah, of course. If you don't have access to a primary angioplasty, definitely thrombolysis is the thing. And mostly in peripheral centers, you will be having only STK, right? I don't think so.
Yeah, so the guidelines are very clear. So if the time to reach a cath lab enabled center is more than 60 minutes, you lyse and then shift. So it's called lyse and shift. If it is closed within half an hour, you have to shift. So that's very clear. Amongst this, the fibrin specific and the non-fibrin specific ones, tenecteplase is the fibrin specific, always better. The opening rates for streptokinase around 30 to 50, and the opening rates for tenecteplase is to the tune of 70%. So definitely it is tenecteplase. Right? Tenecteplase is a little more costlier, but yeah. And then primary angioplasty is 95 plus. So that's the thing. So thank you. I think we'll wrap up that session. Thank you, Dr. Sudeep. Thank you,
you.
Dr.
Thank you,
Anwar.
Thank you.
Thank you, doctors, for that wonderful moderation. Next, we have a question that has become more common than ever. My friend died in the gym last month. I'm really scared, doctor.
To take us through this very important topic, I would like to hand over to Dr. Salman sir. Over to you, sir.
Yeah, hi guys. You're seeing me again. Sudden cardiac death. Right. So, these are things which we see very often. Young chap, CEO, dies of sudden cardiac arrest. Another guy, furniture company CEO, 45 years, sudden cardiac death. Puneet, Kannada star, dies at 46. Then there is KK, the famous singer, dies at 50 on stage while performing. Young chap, 38-year-old guy, CEO of a finance capital guy, passes away. Pepperfry, co-owner Ambrish Muthi, dies suddenly due to cardiac arrest. So many, and these guys are all famous, and that's why they come on paper. Poor guys like us, if we pop off, nobody's going to even talk about it. So basically, this burden keeps happening. One guy dances during Onam, he dies. This is very common, very important, lot of medically relevant topic today, and that's what we're going to discuss. So what is sudden cardiac death? If you want to define it, it's natural death due to cardiac causes heralded by abrupt loss of consciousness within 1 hour of the onset of acute symptom, and pre-existing heart disease may have been known to be present, but the time and mode of death are unexpected. So basically, that's just for definition, nomenclatural purposes. It's unexpected, instant, and non-traumatic. Now, it's the leading cause of death. More than 20% of all deaths globally, Indian and all statistics, around 20 to 25% are all sudden cardiac. And out of all the cardiac deaths, around 70% are sudden cardiac in nature. If you look at the statistics in India also, the number one cause of deaths is sudden cardiac. And this statistic is something which I always show, So cardiac tops the list always. And this is an old chart. But road injuries constitutes only 3% of all deaths. But all the infrastructure and the legislations are all directed towards road traffic accidents and helmets and seatbelts. Nothing towards the 20-25% of the cardiac deaths amongst the public and even as the policy givers. That's the big cause of concern which one should actually be concerned of. Why it matters? Because you often don't have warning signs, public and clinical awareness is less, and prevention is actually very much possible. It kills 4 to 5 million people yearly worldwide. Most of them happen in the presence of witnesses, and 45 to 75 is the peak age. Now, if you want to dissect it, very broadly, obviously, so if you have a more than 35 years person who has a sudden cardiac death is usually CAD, and less than 35 is usually genetic. The statistics say that, coronary artery disease takes the cake most of the time. So you understand that most of the time it's coronary artery disease. Then you have cardiomyopathies. You think of hypertrophic cardiomyopathy, ARVC, non-ischemic cardiomyopathy, that's like your dilated cardiomyopathy, and then the inherited arrhythmias. The channelopathies like long QT syndrome, catecholaminergic polymorphic VT, Brugada syndrome, like Dr. Sudeep discussed. These are the other ones which causes sudden cardiac death. So these three things you keep in mind as the main causes and what one wants to actually evaluate. So less than 35, the youngsters, you look for these cardiomyopathies and channelopathies and rarely coronary anomalies also. And the middle-aged guys, you're trying to look for CAD in their early stages. And above CAD, you're looking at CAD who has above 50, you're looking at CAD who's already set, like those who have had a prior MI and arrhythmias post-MI. I'll just tell you what that means. So when you have CAD, okay, very important. How does CAD predispose to sudden cardiac death? In 3 ways. One, you get an acute MI now, and I get a VT. 20% of all MIs will cause a sudden cardiac death. Why? Because of a ventricular tachycardia, VF or VT. Now then there is another person who doesn't have an infarction, but he gets an acute coronary event like an unstable angina, which precipitates a VTVF, and then he can pop off. And the last person, he doesn't have an acute MI, but he's had an old MI, he's got a scar over there because of the old MI. That is arrhythmogenic, causes the VTVF and causes sudden cardiac. That's how CAD takes care. So these are all the early guys, the late fellows, the elderly chaps usually have something like this, and that causes the MI. So this is what you should keep in mind. You know, an old MI, old anterior wall MI suddenly pops up, he could be having a scar VT. So these are the risk factors, you know, older age, male sex, race, obesity, cardiometabolic, etc. Now, to generally assess, you know, the cardiac red flags, you know, while we are, as physicians, you know, a person says a syncope during exercise, he complains of palpitations, chest pain, obviously, family history, unexplained seizures and drowning episodes. You know, unexplained seizures. We get a lot of patients who are actually treated for seizures, but they actually had ventricular arrhythmias as the cause, causing loss of consciousness with a sort of seizure-like event. So these are the red flags which should at least run through your mind before you prescribe an anti-epileptic. Think, is there a possibility for a cardiac cause of sudden arrhythmic cause? So, you know, you need to do a basic workup. You probably refer for an echocardiogram, an ECG. To look for arrhythmias, look for a Holter, very easily available these days. A treadmill test to look for coronary artery disease. And then advanced things when you do for genetic screening, which I'll explain to you. So for diagnostic of CAD, it's very easy. You know, you do your treadmill, CT, which we mentioned. You have stress echo. You have nuclear imaging, your technetium or thallium, and the coronary angiogram, of course. So special conditions to watch for. HCM, hypertrophic cardiomyopathy, is the most commonest cause of structural cardiomyopathy in the young, which predisposes to sudden cardiac death. So you have to screen for them, and that is best done with an echo, MRI, and ECG evidence. ECG, you get this bizarre LVH, which you need to check out for. Arrhythmogenic right ventricular cardiomyopathy. Just keep that in mind. There is an entity called RV cardiomyopathy, which is well seen in echocardiac MRI, right? You should know of entities like long QT syndrome and WPW syndrome, where the QTC interval is long, like more than 500 milliseconds. ECG is the diagnostic criteria for that. Coronary anomalies, you know, the left is not coming from the left, it's coming from the right, winds in between the aorta and pulmonary artery, gets squeezed up and can cause coronary obstruction-like syndromes. A CT can help. You know, so these are things to understand. The differential diagnosis is also important, to understand what to expect in such persons. How to manage such a situation obviously is beyond the scope of my topic today, but then, you know, we should all be familiar with BLS and ACLS, meaning your immediate public, you know, you're catering to your staff or your family or your workplace should be BLS trained. You should be ACLS trained. Basic. If I ask to put your hands up as to who all are BLS trained, I think we'll have a dismal number. So I'm not going to ask you that. But still, right, shockable rhythms have better outcomes if you have a defibrillator, and then ABC must be stabilized. Right. While we are in the ICU, we look at hemodynamics. Targeted temperature management is something what we do if they survive this SCD, I'm telling, to protect the brain. And diagnosis after survival, after you get resuscitated, that's around 10% of the time, you look at all these things to understand what actually caused the sudden cardiac event. Exercise in SCD. A lot of people go to the gym, you know, and they pop off over there. What happens? The Indian data shows very less data from India. It's around 50 to 100 per lakh population is the cause number of SCD in India, and 15% may occur shortly after a strenuous exertion, right? The statistics is going in favor of, and also in our experience, is that most often they have undiagnosed CAD, right? Most of them have underlying coronary artery disease and not generally inherited conditions. Is the Indian data is what we, and also is something what we see on a routine basis. So meaning to say that more than 35, there is a very high prevalence of silent CAD. It's just like, you know, previously a decade ago, we used to see all 60s in the cath lab doing angioplasties. Today, very uniformly, 40s is the norm right now. Triple vessel disease, sending for bypass surgeries. It's very unfortunate, but this is what we see. Now, very young, we should look for these cardiomyopathies. If you're young diabetic hypertension, silent ischemia, you should look it out. And men have a more risk compared to women. Again, I would like to stress on the fact that the real epidemic is actually premature CAD, which we are missing because we think that we are young, because we think we are fit, because we don't have any symptoms, I will not have CAD. That is quite wrong because we Indians, okay, from the Interheart study, we know that around 2 decades ago, that the Indians, by nature of being Indian, are predisposed to CAD by 10 years prior to their Western counterparts. So if their average age is 65 in the West, it is 55 for us. So that's the problem with being Indian. If you're a Keralite, you're even worse. Now, yeah, the risk factors like hypertension, diabetes, smoking are all present in the young. Okay? And family history is also important. In athletes, you look for hypertrophic cardiomyopathy. That's very important. That's again a Western data mostly, but then again, it's very important for us also because very common. So pre-participation ECG and history is very important. And yeah, so we know that exercise is medicine, but it can have its own set of problems and can backfire. So as physicians, as GPs, as clinicians, we should understand that pre-participation screening, when somebody comes to you, saying that can I go to the gym, pre-participation screening softwares and questionnaires are readily available. These are to be used not only by us, like physicians, but also by trainers, by trainers, physiotherapists, and people who are actually engaged in prescribing exercise to people, like sports trainers, gym trainers, etc. So, this is like one thing called ACSM, pre-participation screening. So you just have to do tick, 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 and then they will tell you that whether you need a medical clearance or not. So suppose if you don't have, you have no, that is no, the physical activity is less, no known disease, no signs, you don't need a medical clearance. It's very simple to understand for yourself in an objective way whether you need to refer for advanced medical clearance before prescribing moderate to heavy intensity exercise. A lot of studies have shown that although 50% trainers knew about pre-exercise risk stratification, 64% did not follow them. This is in the West. Here, though, it will be 0%. Definitely. Too much of a good thing is bad. There is the famous U-shaped curve for exercise, So no exercise, very bad health risk. And then once you start exercising, your risk, a lot of benefit happens. But if you go for really high intensity, it can backfire. And this is called the extreme exercise hypothesis, which is a topic of controversy as to what happens. It's probably because of myocardial fibrosis, increased AF, transient RV dysfunction, a lot of hypotheses happening. The U-shaped curve, for more the exercise, sometimes it can backfire. You should always have an emergency plan. As caregivers, as physicians, you should, guys, prescribe a backup plan for everybody. Like, what is the best chance of survival if you have a bystander CPR and the use of AED within 3 minutes. As it is, the survival for a sudden event is only 10% in the best of centers in the world. If you don't have bystander CPR, if you don't have any AED, you're dead. You're gone. So this is what a must-have, what you should encourage your circle, your radius should have emergency contact processes, usage of AEDs, training of BLS is extremely important. Yourself first and then people around you. BLS is for the common public. ACLS is for you guys. You guys and we guys need to know all of these. Educate local trainers, pre-exercise clearances, host BLS workshops. This is, not many of us know how to use an AED also. This is very famous 2020 Euro Cup. Eriksson from Denmark suddenly collapses while playing on the field. He just falls flat. This is in the Euro Cup 2020. Everybody gets psyched out. The medical people come running in. What's happening? Now, this is something which is very common. And then people start looking, checking your pulse, and they start initiating CPR. The whole world is shocked. You can see the person doing CPR over there. So he is a professional athlete, okay? And this is what's happening to him. And this is how he looked like when he fall flat. He just conked out. This is what happened. But, so every minute without CPR, survival rate decreased by 10%. The survival rate is only 10% for such a person. If you have the right resources, you will come back. 2 years later, he scored the first goal in the first 5 minutes of his next match in the this thing by scoring a goal. What he is covered with his right hand is an ICD which he has got, an implantable cardioverter defibrillator which was implanted to him after this event to prevent. Because he had some genetic thing, the diagnosis wasn't revealed, but an ICD was implanted for prevention of sudden cardiac death again. So who gets an ICD? is if you survive a such an event, that is called secondary prevention. But primary prevention, without getting that event, if you have an EF 35, less than 35% after an MI, after a month, or a DCM, less than 35%, you should get an ICD for prevention of sudden cardiac death, right? Secondary prevention is if you something like Erickson, if he had an event, you should put in one to prevent, or a documented VT, VF, and you survived that event, you should get an ICD. And it has revolutionized the management of sudden cardiac death prevention. ICD's relative risk reduction is 50%. No current treatment in today's medical technology has a relative risk reduction to the tune of 50%, like what ICD has done in modern day cardiology. Pharmacological measures, beta blockers, amidon, has all been compared against ICDs, but has not beaten ICDs for the prevention of sudden cardiac death. So just imagine Erickson, a professional level footballer, is playing around with an ICD. Extremely gratifying to know that the usage of technology now helps people to live their lives better. Public health perspective, as I said, public access AEDs and BLS should be prevalent. Recognition early CPR is the need of the hour. Okay, I'll give you a couple of cases before wrapping up. Young gym goer collapses during a treadmill. He was diagnosed with HCM on echo. So he was missed, and therefore this is what causes arrhythmia, a hypertrophic cardiomyopathy with obstruction, easily caught by echo and an ECG. Middle-aged smoker dies suddenly with atypical symptoms. 45-year-old. What happened? His autopsy showed that he had an MI. So basically it was premature CAD. It was missed. It could have been prevented by a easy checkup like an echo, treadmill, checking out for the risk factors like diabetes, hypertension, cholesterol. This guy is my patient from Dubai, 42-year-old gym trainer. He's like perfect 6 packs, Allah. He's got some 20 packs, whatever. He's just shaped out like a Greek god. He was a 40 years age, Mr. India candidate, chest discomfort while doing his, we talk about half an hour exercise, his exercises from morning till evening. And he had a coronary angiogram done because of a small chest discomfort, and he had diffuse triple vessel disease and advised a CBG in Dubai. He came to me for a second opinion. We did an angioplasty. He's doing well. But then the question is, why does he get it? So this is what I exactly told. So we are missing out on CAD because and then when you start asking his history, his elder brother died 6 months back because of a sudden cardiac event. So you cannot beat genetics. You cannot beat genetics. You got to check for it early and then treat appropriately. So, in spite of his excessively healthy lifestyle, this is what he got. He survived. But then, checkups are extremely important to understand. This is another young lady, a house surgeon based in Trivandrum. So, because somebody, she came to neurology because a sudden cry during sleep and involuntary urination. Very nice story. So, then I asked her, so how did anybody hear your cry? So then she said, because my parents found it out. So how do your parents find out why you're crying in your sleep? Because I was sleeping with my parents. So why is a 28-year-old sleeping with your parent? Because my younger brother just died last week. And therefore, because of that sadness and grief in the family, I was sleeping with my parents. So that's the big story. Why did your brother die? So he was coming in a marriage ceremony in the last of the bus. He was just tired after after song and dance. He just lied on the bus and just suddenly collapsed. They tried to do CPR, but just died. He was 4 or 5 years younger to this lady. And that was very tragic. So one kid, that parents lost one kid, and this second kid has got some funny thing going on over there. And we evaluated her. The neurologist couldn't find anything. We did an evaluation. The ECG showed a long QT interval. That was very subtle pickup of a long QT interval. We did a genetic study on her. She was found to have the SCN5A mutation for long QT syndrome type 3. And we eventually put her on beta blockers. We put an ICD on her. She was extremely challenging situation. A young, beautiful lady in the prime of her time, ready to get married. And just imagine the paradigm shift of what's going to happen to her if I put an ICD. We had a lot of discussion, but then it's about life. Just exactly 2 months later at 1 a.m., she put in that device where I get a remote control beep whenever she gets a shock. She gets a shock. She gets a shock while you're sleeping. And the rhythm comes to my mobile, which shows that she had a malignant ventricular fibrillation, and it shocked, and the ICD saved her. So she was scheduled to die at that point of time. So just imagine those parents who lost one kid, and they were scheduled to lose her also. But because of this guy here, subsequently she has received a couple of shocks in the last couple of years. And but every time it's a malignant VF which happens. We're trying out a lot of drugs to prevent it, but then that's it. So this is sudden cardiac death in young, that's a life saved. And the role of the primary physician is to understand, catch these red flags, catch these symptoms, educate, and don't miss these red flags because it is a significant health burden. It can be preventable occasionally with vigilance. Early identification of risk individuals can save lives, and team-based and public health initiatives are very, very important. Thank you.
Thank you, sir, for sharing such an important and insightful talk. We'll have Dr. Firoz sir back on stage to moderate the session. So, please.
There's rare instances where I have to moderate myself.
Thank you, sir, for the wonderful eye-opening session on sudden cardiac death.
Yep. Yeah, so those who are on the screen can go back to menti.com with the code, and Dr. Firoz can have a look at the screen.
So, a GP should suspect risk of sudden cardiac death in a patient with palpitations, chronic back pain, prior MI, and an EF less than 35%, and hypertension.
Yeah, so a lot of people are going towards the right direction. It is. So an MI with less than 35% is a huge risk towards SCD. You know, LV dysfunction, left ventricular dysfunction, is a strong independent marker for sudden cardiac death, ventricular arrhythmia. Palpitations, yes, occasionally it's possible, but since it's so very non-specific, in the face of this particular choice C, we have to go with option number C, which most of them. So, and as I said, according to the MADIT-2 trial and the MADIT-1 trial, Dr. Firoz, there was an class 1 indication for an ICD 35 days after an MI if you have a low EF. It prevents lives, yeah.
So, in young athletes, the most common structural cause of sudden cardiac death is aortic stenosis, hypertrophic cardiomyopathy, COPD, AF.
Yes, so a lot of people have got it right. Hypertrophic cardiomyopathy, that's a take-home message. HCM is the most commonest genetically inherited cardiomyopathy, and it can cause. Usually, a lot of people are very well medically managed, but yes, take home that they can have exertion symptoms as well as arrhythmic symptoms both. Atrial fibrillation is common. Ventricular arrhythmias are also common. Fantastic, great. So a lot of people have got that in mind. Yeah.
So, the which ECG findings increases the risk of sudden arrhythmic death? Left axis deviation, low voltage QRS, first degree AV block, or QTC more than 500 milliseconds.
Yeah. So again, an easy question. So QTC, how often do you think, Firoz, somebody actually looks at the QTC on the ECG?
Like most of us like in a first time reading an ECG most often miss the QTC, but as sir have mentioned, the QTC is an important part. So the like last case he has mentioned long QT syndromes, the genetic parts, the relationship with the sudden cardiac death with the QTC, all these things it's important to look for the QTC, and we have to see for the other causes of the QTC prolongation, the drugs, all those things also has to be kept in mind.
So QTC, for those who are very bored to actually, the 12-lead ECG computerized, it's actually written over there. If you know something around 400, less than 400 is fine. More than 500 is a red flag. Think about it. So why is it a red flag? Long QT syndrome is a congenital syndrome, but then you can have these acquired things. Yes, Dr. Firoz. So we want to mention something about these medications and electrolytes which actually predispose to that.
Yeah, just I have mentioned the other causes, secondary causes of this long QT, the medications, most commonly the macrolide antibiotics which we are using, the quinolones, antipsychotics measures, azoles, then methadone, then electrolyte abnormalities. Most common will be hypomagnesemia, we will be thinking, but hypokalemia and hypocalcemia also has to be kept in mind. So the QTC more than 500 is 5 times higher risk of TDP in patients, and they can degenerate into VF, causing sudden cardiac death.
Yeah, so that's a very important red flag which one must see. Right.
Oh, and in hospital, in an out of hospital collapse in a public area, the most impactful intervention that improves survival is IV adrenaline by bystanders, bag and mask ventilation, availability of the automated external defibrillator, and or checking the pulse for 30 seconds.
Yeah, so a lot of people are getting the AED right. So we take a lot of classes of basic life support for the general public, and a lot of people don't know about AEDs, and the AEDs are available in your railway station, highlight mall, airport, corporate offices, how to use one. Yeah, so getting to know that, how to use that is all very important. And that increases survival dramatically in a sudden cardiac arrest situation. Okay, so that's how an AED looks like. Right, so that wraps up our talk on sudden cardiac death. All of us, any questions, we'll be glad to answer on this extremely relevant topic in today's. In your experience, does manual laborers met VD, CAD quite well?
From the audience perspective, how will you differentiate an vasovagal an episode and an arrhythmic event, sir?
Yeah, so a vasovagal is very commonly associated with certain triggers. So it's also called reflex syncope. So the other name of this thing is neurocardiogenic syncope or reflex syncope. So it's either pain or some other triggers. It can be cough, it can be micturition, it can be an acute painful event, and a predisposition to develop that in terms of dehydration, low blood pressure, etc. And arrhythmic, again, the substrate. Elderly chap, previous CAD history, coronary history, something like that. So that's the way. And otherwise, you have to investigate prospectively in terms of ECG, Holters, etc. So we've got some this thing here. Manual laborers, do they get CAD quite often? Anybody can get CAD. I showed you the gym guy who got CAD. It's a really tragedy. Anybody can develop, but yes, lifestyle diseases would be less for them, like diabetes, hypertension, if they're. But again, all those which have a genetic aspect, if you want to get, if you're scheduled to or destined to get these things, I think you will get it. But yeah, it will be less.
When can a person resume physical activities or exercise after an MI?
Yeah, so generally, large MIs, we talk about a month. Large MIs, we talk about a month, and that's when they start their thing. That's rehab, cardiac rehabilitation starts after a month. The minor unstable anginas and all, you can probably say 2 to 3 weeks. What test to do for police candidate NCC fitness? Yeah, I don't know. Sorry? Yeah, okay. I usually do whatever they tell me to do. If they, there are these guys who want to go for a pilot, and a lot of people come to me, and they have certain prescribed things which they want to check. If they say they want a cardiac check, so I get an ECG done, and since we have echocardiogram freely available, so get an echocardiogram done. Anything high intensity, probably get a treadmill also done. But generally, as I said, for most people, an ECG is more than enough. Yeah.
The test, what test does a young gym goes to rule out any cause for the cardiac death? As sir has mentioned, the basic ECG, echo, all those things you have to correct.
People are getting hungry, and hence the A. Kurimandi, biryani.
We'll put a poll on that, I think, sir. A. Kurimandi, B. biryani, C. Sadhya plus fish sheet.
Yeah, I don't like mandi per se, but yeah, biryani, fish fry. Sadhya fish fry sounds good. Okay, so what is malignant VF? I don't think there's anything called malignant. All VFs are malignant. VF is death. There's no malignant VF. VF is equal to death. There is no shortcut for VF. If you don't shock, there's no amiodarone, there's no beta blocker, there's no magnesium, there's nothing. VF is equal to death. So I don't understand why anything should be malignant. More malignant than there's nothing more malignant than death. VF is equal to death. So VF is VF. Is stress a cause for SCD? It depends on what is underlying. How to refer a patient after shock with an AED? He has to be totally evaluated as to why that person developed that person. Is it a genetic? Is it a structural cardiac disease? Is it CAD? Does obese patient less than 30 planning to weight loss undergo these forementioned tests? Less than 30, the incidence of coronary artery disease is very less. But generally for weight loss, I think less than 30, the risk factor is very less. I think it should be okay. Drug abuse and MI, a lot of cases we are getting with drugs. It's of course the incidents, especially cocaine, even cannabis. We've seen a couple of cases in youngsters. Polycythemia and MI, again, it is, I wouldn't say common, but it is there. I have a couple of patients in my list. Someone, you look very young, but you have a lot of degrees. How's it possible? Your age, please.
Coronary ectasia is a risk factor.
Coronary. Yeah, so sorry, there are a lot of distracting questions. So we're not able to go into academics. So I'll skip my name questions. What did you say, sorry? Coronary ectasia. Yeah, coronary ectasia can cause MI. It can cause MI by virtue of it being ectatic and causing a prothrombotic this thing. Is lunch available? Of course, it is available. Fantastic lunch. Everything is due to vaccine. It's a very commonly asked question. Everything is due to vaccine. That's wrong. Not because I'm pro-vaccine or anything. Because we are all, my professor in AIMS used to tell me that only God knows the truth. The second best available source is science. Okay? So God knows where the vaccine is. But science is now telling us, ICMR has published a large study, 800 patients of sudden cardiac death, and has correlated with the vaccine and it's come out negative. So we believe that as of now. Tomorrow somebody comes up with a better paper, we'll think about that. So science now tells us that it's not due to the vaccine. Because we see patients day in and day out with triple vessel disease and this. The vaccine can't do that. Corona used to cause occlusions through prothrombotic state, not plaque deposition. Plaque deposition is because of all this thing. Is DRNB cardio worth in MIMS? It's fantastic. Dr. Firoz,
Bombastic.
Bolo. Yeah. All fantastic people. Will you give fitness for pilot training for a person with Brugada pattern? Very interesting. If you're going for pilot training, you have to go for further aggressive testing like Ajmaline testing and flecainide testing to rule out and unearthing a Brugada syndrome, which is going to be quite the same. Cooking oil and CAD, it's a vast discussed topic. Which is the best oil? It's topic of controversy. What I tell everybody is whatever oil you use, just use it in moderation. That's the thing. Do you get any ST changes in pediatric ECGs? What could they be? That is the topic of ECG masterclass workshop which we will be held next time. Right? Thank you very much for your kind thing. There's one more question last, sorry. In that, I saw that in the clinical scenario of that young doctor with genetic history, could the sudden cry and involuntary in any way related? Yeah, so she got a VF, nah. So she got a VF, she was scheduled to die and she had an LOC, seizure-like event. So that was VTVF. But then she luckily survived. Her brother didn't survive because of the VTVF. That's called pure luck, God's blessings at that particular amount of time. That's why even after the ICD, we documented VF. We documented VF and the ICD shocked her. So that's what, that involuntary cry was a cardiac event, which probably looked like a seizure. So that is the thing. Okay. So thank you very much. Thank you, Dr. Firoz. Fantastic there.
Sir, for the fantastic presentation.
Yeah. So yes. So that wraps up our our scientific session. We have the last wrap up with we always finish up with our quiz because we're going to be giving all sorts of fancy prizes. We're going to be giving apartments, gold, diamonds. Yes, Salim? Yes.
So before we wrap up today's program, we move on to one of the most anticipated parts of Back to Basics, the classic.
Yes, the quiz hosted by our Salman sir based on everything we have covered today.
It's always lively, always fun, and yes, there are exciting prizes for the winners. So please sit back, listen to the instructions carefully, and follow along.
And with that, over to Salman sir to take over the quiz session. Sir, please.
Yeah, so guys, just go back to menti.com. We've just changed the number, okay? So we've changed the number. The number is different. Let's see if I got it. Yeah, so it is this number on the screen. I'll read it out for you. So it's a different presentation because since we're giving gold and diamonds and apartment complexes, 3-bedroom. So we changed the code. 661-20515. Mohiddin sir is not joining the quiz because I think it'll be interesting. You can get some exotic prizes. Yeah, so anybody has any issue in joining, please raise your hand. Our team will help you. Anybody has an issue, just go to menti.com, put in the code, and you will be in sync with my presentation. All extremely challenging questions, world-class questions. Okay, good. So I think we got some 100 people on this thing. That's fantastic. 103 people are still joining. Okay, 661-20515, menti.com. Everybody's in. Log out of your previous session. Go back to menti.com. And, yep. Okay. Right, so, yeah, that's the code again. If anybody wants to put in a QR. Yeah, so we're getting a lot of love. We're getting a lot of likes here. Fantastic. Okay, right. On your marks. Get set. So I'll building up the suspense. Okay. So now what happened is, you'll be instructed, in the next slide, you'll be instructed to type your name. Okay. So put in your proper names instead of something weird, so that then only you will get the 3 BHK apartment. Otherwise, you will not get it. Okay. So in the next slide, I think, so now I think the name thing would have started happening. So these are all of you guys have an emoji, okay? So you guys got, so there are, all these guys are you guys. A unique icon. So you can look at it and then be happy that you're there on the screen. So we've got 120 players for the quiz. And okay, so I think we will proceed. So we'll have initial few sample sessions to understand just 20 questions. So you have to answer quickly to get more. So more quicker, more accurate. Which season of Back to Basics are you in right now? Season 5, Season 6, Season 7, or Season 8? So the fastest and the most accurate gets the 3 BHK apartment and diamond necklace. Okay, so this time is up. A lot of people answered the right answer. There are few 7 plus 3, 10 people who are not looking at the screen. It is there, Season 8. And that's because of the hunger pangs. Okay, so then we get a leaderboard to understand who is doing well. Okay, so Arjun can be ready for our first prize. Loki is the fastest. I'll give a big round of applause for Loki, who is very fast and very intelligent and knowledgeable. Okay, so question number 2, everybody's ready. Everybody look into your screens, and we are going answer quickly to get more points. What is the capital of Kerala? It's very, very challenging questions here. Vadagara, Koilandi, Munnar, or Thiruvananthapuram? It's very, very challenging things to understand these things. It's very, very difficult stuff. You have to fight for that apartment. You have to fight for it. Luckily, there are no people sleeping and who thought because I said apartment, that's why everybody is doing correctly. Previous sessions, people had marked Koilandi and Vadagara. Okay, so let's see who is. So this thing, the algorithm continuously keeps reshuffling. Okay, and again, Loki is the winner in this. That's good, that's good. Very intelligent. Loki is very intelligent. Very intelligent because of these difficult questions. Okay, we're going for the next question. Answer quickly to get more points. The star in Hriday Purvam Insta is. It's a very difficult question again. Mohanlal, Mammootty, Dr. Sandeep Mohanan, Mamu Koya. So, I know everybody's laughing, thinking they know the right answer. The answer is not Mohanlal. A lot of people who thought it was Mamu Koya. It is not right. The star is actually Dr. Sandeep Mohanan. Where is Sandeep? Yes, give a big round of applause to Sandeep Mohanan. Yeah, he is part of a very up and running Insta page called Hriday Purvam. We are all small co-stars along with Sandeep. Where is Sandeep? Yeah? Sandeep, bye. Yeah, so, and that is Hriday Purvam, our small Insta page. You can all click on it, subscribe, like, and follow. That's the dialogue, eh? Yeah, okay, cool. So that is that. So Mohanlal is the wrong answer. The answer is Dr. Sandeep Mohanan. Yeah, so see, there you go. So now it's going to change now. Loki is gone. Loki got it wrong. So you got to get everything right, and S22 has, I told you had to put proper names, man. S22 is not a name. You might not get the apartment. But anyway, so the fastest was not you, but it's a algorithm is the most fastest, the most accurate. Okay, so you saw that Loki got it wrong, so therefore Loki is not on the list. Whoever Loki is. Okay, so now after this question, you're going to get a bonus prize. Okay, it could be the apartment. Arjun, be ready with the prize. Okay, after this question, the leaderboard will get a prize. Okay, everybody's ready. Okay. Answer quickly to get more points. Well, let's see which question. The population of Kerala, this is a serious question. Okay, no problem, not jokes. Okay, is 2.6 CR, 3.6 CR, 4.6 CR, 5.6 CR. Which is the population of Kerala? What is the population of Kerala? See, you thought I'd just make jokey questions. No. Serious business. Serious business. A lot of people got it right. The answer is 3.6 CR. Very correct. Fantastic. And now let's see. Arjun. Come, yeah, the small one. Okay, and yes, Aman Ishan is the leader over here. Aman Ishan gets the first bonus prize. Aman Ishan, please. Who is Aman Ishan? Aman Ishan. Please, who is Aman Ishan? Come on. I would request Moideen sir to please give this prize to. Moideen sir is our most sincerest attendee of Back to Basics. Please give the prize to Aman Ishan for his very intelligent answers. Okay. Right. Thank you, sir. See, so that was the bonus prize. So the real stuff is coming up right now. Okay. So now we're going to start the business. Now time to get serious. Okay. It's serious. Okay. Anyway. Okay, now some academic stuff, huh? Ready. Enough of nonsense. You ready? Okay, start. Answer quickly. CO2 angiography cannot be used in. Carbon dioxide angiography cannot be used in aortoiliac cases, patients with CKD, coronary arteries, femoral disease. It cannot be used in. The time stops now. It cannot be used in coronary arteries. The answer is coronary arteries. It is the class 1 indication for in CKD. As I mentioned, it is a negative contrast agent. You can use it for patients. We use it routinely for lower limb angiograms for patients with CKD. Aortoiliac, it can be very well used. And femoral artery, it can be very well used. Below the diaphragm, it can be used. Above the diaphragm, because of the small risk of air embolism to the brain or the heart, we do not use it for coronaries. Above the diaphragm, no carbon dioxide. Below the diaphragm, yes, carbon dioxide for CKD. Okay, good. So that's good. And so we have a leaderboard which keeps auto-regulating based on one's performances, accuracy, speed. Aman Nishan continues to lead. The next one is the next question coming up. What is the primary indication for transcatheter aortic valve implantation? TAVI. Severe aortic regurgitation, severe aortic stenosis, severe mitral regurgitation, severe mitral stenosis. We discussed about TAVI. It is used in which valvular condition and for what is it used? Very easy question. It is used for severe aortic stenosis. There are people who got it for others. In severe AR, we do not use it. It is used for anecdotal cases only. The answer is severe aortic stenosis. As I mentioned earlier, when you have a prohibitive surgical risk or a high surgical risk, TAVR becomes very good. Even in intermediate risk, class 2 indications you may use today because it's coming up right now for severe aortic stenosis, especially in the elderly. Okay, So that is that. So I will skip this leaderboard so that will be a suspense over there. For the next question, we have CT coronary angiogram has excellent positive predictive value, negative predictive value. It's a very classic statement for CT coronary angiogram, which I mentioned during my talk. What is its unique potential is that it has an excellent negative predictive value. So it means that, so once you have, so negative predictive value means that if it says that there is negative, no disease, it is a fantastic and very, very accurate test. Now, sometimes if the report comes that there is some 10-20% stenosis, the positive predictive value is there, but it's not as good as the negative predictive value. So you may have some issues with the percentage stenosis, you may have some percentage with artifacts, but if it says it is clean, it is normal, it is normal. The negative predictive, the ruling out disease is fantastic with the CT coronary angiogram. Again, for this leaderboard, let's see who's picking up. Loki has gone out of the race. Hasna is picking up with 6159 points, although Abdullah was fastest. It was less accurate. Okay, so this is how it works. You got to be fast, you got to be accurate, and then only you will get the 3 BHK apartment. Right. Okay, the next question on screen is clue which favors early repolarization versus STEMI. Early repolarization, which we mentioned, is it reciprocal ST depression, J-point fish hooking pattern, PR depression, or Q waves, which favors early repolarization abnormality? Very much discussed in detail with Dr. Sudeep Koshi's class, and the answer is a J-point elevation. Reciprocal ST depression does not happen in early repolarization. It is a classic feature of STEMI. PR depression happens in pericarditis and not in early repolarization, and QAs are for old MI. So that is the J-point fish hooking appearance for early repolarization. You should understand, I don't know how many people understood this, See, early repolarization means if a person has, if I have this, my myocardial cells, my myocytes are, repolarizing just a few milliseconds early. So imagine if that ST was a little here, somebody just pushed it. Just pushed it. So it's all bunched up over there and causing that fish hook over there. So it was a little bit later, it will be looking normal. So because it is a little early repolarizing my myocytes, that's why it looks like. So it will always be like that. Okay? So that is why this thing is important. So you see a patient with this kind of ST elevation, you look for his or her previous ECGs, and then you understand that this is unique for that particular person, and that's what we can see. Okay, so a lot of rearrangement happening in our leaderboard. A lot of people are going up the ladder. That's good, that's good. Keep trying, keep trying. You still have till the last shot. We still got around 9 questions left. Right. ABI less than 0.4 is associated with ankle brachial index, claudication, critical limb ischemia, normal perfusion, or is it a falsely high reading? Okay, so we discussed that ABI is normal value, and we discussed a value which is less than 0.4, and the answer is critical limb ischemia, or like Dr. Bijoy mentioned, the term which is more fashionably used now is CLTI, or chronic limb threatening ischemia. Okay, so most classifications say 0.4, some people say 0.5. Nevertheless, very low classification for is it's one of the cutoffs for CLTI. I'll skip this for suspense. Okay. The next question coming on the screen right now is on sudden cardiac death. Most common cause of sudden cardiac death in adults is pulmonary embolism, aortic dissection, ventricular arrhythmia due to ischemic heart disease, or long QT syndrome. The answer, I think, is sort of straightforward. Yeah, so the answer is ventricular arrhythmia. Yeah, so as I mentioned in adults, so probably a little in younger individuals, it would be more genetic, like the long QT syndrome. Aortic dissection, pulmonary embolism are all indeed causes of sudden cardiac death, but it will not beat VF and VT due to ischemic heart disease or coronary artery disease as the most commonest cause of sudden cardiac death. Right. Okay, fantastic. You guys are doing great. I'll skip this again for suspense. Okay, get ready for the next question. Right. A relative contraindication for CT coronary angiogram is, right? Atrial fibrillation, stable angina, hypertension, and age more than 60 years. Okay? So, which would you be a little bit skeptical in sending the patient for? Yeah. So the correct answer is atrial fibrillation. People thought about age more than 60 years and stable angina. I'll explain to you. We need a relatively stable heart rate for getting a good test. If you have an irregular heart rate, you are likely to get a lot of artifacts, and therefore atrial fibrillation becomes a sort of relative contraindication. Stable angina, if it is stable, you may do it to understand. Hypertension is absolutely not a contraindication. And again, age more than 60 only becomes a problem if the patient has some amount of CKD or disturbance in the GFR. So the answer is atrial fibrillation because you need a stable heart rate for CT coronary angiogram. So just have a look at this, going from left to right. So the right is the one which is a good picture. The one on the leftmost, the one over here, is because of a rate-related artifact, and therefore you see if you get a report like this, it becomes extremely difficult to understand what is this. This is why the positive predictive value is a little problem, because if something happens like this, you say it could be there. So then the correct positive predictive value is not 100%. But if you say that it is not there here, there is no artifact here, and I say it's normal, so the negative predictive value is very high. When I say it is not there, when CAD is not there, that statement is very accurate for CT coronary angiogram. That is why the negative predictive value is very high. Right. So because of the problem of artifacts and something like that, which happens once in a while. Okay. So this is a little difficult. A lot of people didn't get this particular answer. Shahana Begum is going off the charts. The next question, people get ready, answer quickly, answer fast, answer accurately. Toe brachial index is useful in. Dr. Bijoy mentioned this. Young healthy individuals, COPD patients, diabetics and CKD patients with calcified ankle arteries, and patients with varicose vein. Where will you use a toe brachial index as opposed to the ankle brachial index in the diagnosis of peripheral artery disease is the question. And the correct answer most of you have gotten, because a lot of medial calcification happening with diabetics and CKD, and the ankle brachial index may be falsely high, and that could be a problem. Therefore, use the toe brachial index. Yes, that's just to understand that particularly that these things are important. You should know the gamut of tests which are available for you to diagnose peripheral artery disease. CT calcium score 450 indicates immediate angioplasty, needs statins, needs valve replacements, needs anti-anginals for CAD. When you have a CT calcium score of 450, what should be your intervention at this particular stage of time? This I discussed in the topic on cardiac CT, needs angioplasty. The correct answer is needs statins. People who thought that angioplasty, as I mentioned, I'm going to say it again, CT calcium score does not tell you that a person has got blocks. It tells you about cardiovascular risk. That there is an atherosclerotic risk burden is a little high, so you need to modify that risk burden with statins. Valve replacements and all is totally out of the question. These 8 people are truly hungry and they need their lunch very fast. We'll try to order some packed lunches for you. We're going to be catching lunch in the next 10 minutes, don't worry. Okay, I'm going to skip the leaderboard again so that to understand where we are standing. Okay, just the last 5 or 6 more questions and then we're going to wrap it up. Critical limb ischemia. Which of the below suggests CLI? Calf cramps, claudication, rest pain for 2 weeks, foot numbness. So critical limb ischemia is a very important concept to understand. I don't know how many of you got it in the discussion, but the answer is quite easy. It is not claudication. It is rest pain for more than 2 weeks. You understand that peripheral arterial disease can have claudication, that is pain in the lower limbs while walking. Critical limb ischemia is defined as the syndrome of either rest pain for more than 2 weeks, the presence of tissue loss in the form of ulcers, or the presence of gangrene in the setting of peripheral artery disease, which means that their patient has got a block in the lower limb arteries, but there is some criticality which happened which caused rest pain bad ulcers or gangrene. Rest pain, bad ulcers or gangrene is what is called critical limb ischemia. Claudication is not critical. Right. So that's the rest pain, tissue loss, or gangrene. So in the setting of peripheral artery disease, the syndrome of either one of these three is the definition of CLI or CLTI. Again, I'm going to skip the leaderboard for suspense, and we're going to the fag end of our quiz very slowly. ABI is 0.55 in a smoker with claudication. What is the next best step? You want to do immediate angioplasty, you want to do supervised exercise plus statins plus antiplatelets, you want to give a foot massage to the guy, or you want to give warfarin. So you have a low ABI. We said that an ABI of 0.9 or more is normal, and so supervised exercise. So immediate angioplasty is not required in patients with claudication because not critical limb ischemia. He may eventually need one, but supervised exercise, organized exercise is a class 1 indication for patients with claudication. All these people, chaps with peripheral artery disease, should undergo organized supervised exercise. It does a lot of good to these patients by the formation of collaterals, right? Okay, fantastic. Let's see who's picking up over here. Nikita is sort of crossed out. I don't know why. Shahana Begum is coming up again. Fantastic. Amanishan was fastest, was not able to pick up with the likes. There are a lot of ladies in the top over here. Fantastic, fantastic. Very good, very good. Last few more questions. CT calcium score 0 means what? CT calcium score 0 means no risk, MI is excluded, statin mandatory, very low 10-year event risk. That's an easy question. I mentioned this several times in my talk, that CT calcium score of 0 implies a very low 10-year event risk. So there's no risk Allah. It is a very low 10-year event risk. It means you don't have a very grand risk, but non-calcific plaques may happen. Okay? Fantastic. I'll skip this leaderboard for suspense. And strongest predictor of sudden cardiac death in heart failure. EF less than 35%, smoking, hypertension, age. Again, that's an easy answer. These are just to drive in the concepts to you that when you see a patient, such a patient like this, with an EF less than 35%, that is the strongest predictor. These people have a definite, it's up to the tune of 30%, the risk of sudden dying. So that's a big number, and they should be advised either medications or an ICD, and that's what we need to do. What's what we need to offer them. Okay, the last 3 questions coming up. Everybody's getting ready to get their grand prizes. Oh my God, the excitement is bundling up. Get quick, get fast. You can get a new house. Which of the following can mimic anterior STEMI? RBBB, LBBB, BBBB, ABCD. Which can mimic an anterior STEMI? RBBB, LBBB, BBBB, ABCD. Yeah, a lot of people thought it is ABCD and BBBB. So that's also fantastic. The answer is LBBB. RBBB cannot mimic an anterior STEMI. It can be part of an anterior STEMI if you have a QRBB. So this particular LBBB, because I'm seeing a lot of BBBBs now. Okay, so this particular ST elevation is a part of the repolarization abnormality for left bundle branch block. So this may look like a anterior STEMI, but it has to follow Garbosa's criteria. Only if it goes above 5 mm, then you can think of an MI there. Okay? Or it's not going up, it's going down. That's also Garbosa positive. So that's LBBB and not RBBB. I'm going to skip the leaderboard again. And the 19th question is, duplex is poor at imaging what? The duplex ultrasound is poor at femoral artery, aortoiliac segment in obesity, popliteal and tibial arteries. So that's an easy question. So basically, this is an easy imaging tool for diagnosing peripheral artery disease, and you very well are able to get the lower limb arteries, but the aortoiliac segment is poorly visualized, and therefore you may need something like a CT angiogram to diagnose. Okay, I'm going to skip the leaderboard. The penultimate question, the second last question, Everybody has to be really ready for this because it's, it's a life and death situation, and it's very important. Primary advantage of CO2 angiography is that high opacification in below-knee arteries, safe in renal failure, better spatial resolution, high opacification above the diaphragm. What is the primary advantage of carbon dioxide? Again, it's a new concept for a few of you guys. Carbon dioxide, as I mentioned, is used a lot in renal failure. Its opacification is not very great as contrast, usual contrast. So therefore, that is not a correct answer. Below knee, it's actually quite poor. It's very good for iliac. And above diaphragm, it should not be used. And the spatial resolution is best for contrast. Okay? And now, we're going to skip this, the last question. We should have some background music, Yes. The last question, which determines who is going to get, who's going to get, that Kaun Banega Crorepati time. Aakhri sawal. Yes. Right. Okay. Here goes. So this is a, this, you have these exam books, past questions, why saying exam karakkam pettumnalla. This every year we have a question. Past questions answer yeah, it's a cheat question. Identify the person. It's a very difficult question. Okay, so the options are. Okay, so it's very difficult. Everybody is wanting to answer. Answer quickly to get more points, quickly and accurately. Identify the person. Is it Ahmed Koya, Pakar Koya, or Mamu Koya? And let's see who gets the correct answer. Arjun, please come on stage, please. Ta-da! Yeah, so Pakar Koya is also there in the list, and Ahmed Koya is also there in the list. And with that, we complete our quiz. Where is Arjun, sir? Arjun. Vidil, yes, Vidil, come. Okay. Fantastic. And therefore, we are now going to go for the leaderboard. And the final is coming up. And the winner is Rima. Yes, fantastic. I will again invite Moideen sir up on stage, our senior most faculty over here. Because this is the actual final thing, So first we'll give the first prize. First prize in the Yeah. Moideen sir. Yes. Who's this? Revant, come on. Please come on stage. So he gets a fancy JBL state-of-the-art. It's not a 3 BHK alla. Patichada. Give a big hand for Raymond. Right. And the second prize goes to, you stay, 3 prizes. Second prize goes to, we'll stay together. Dr. Imran. Yes, copy it. Cheating. Same. Congratulations, Dr. Imran. You are from? KMCT. Dr. KMCT. KMCT Nexus. Yes. Okay, again. Congratulations. Dr. Imran. And the third prize goes to Dr. Akhil. Yes. He was also one of the winners of last year. He's a consistent attendee of Back to Basics, like Moideen sir. Everybody give a big hand. Thank you very much, sir. And with that, we wrap up our this thing. We have finished at 2 o'clock. And thank you very much. I take this opportunity to thank each and every one of you all the delegates who have come in from near and far. I would like to invite my co-colleagues, my presenters, Dr. Bijoy, Sudeep, Sandeep, Anwar, Firoz, Jinshi, Sadiq, Chandni, Varshit, everybody on stage. On behalf of my department, I have a huge department behind me, 150 people in our department who are the backbone of behind what you saw today. I hope all of you guys had a good time in terms of understanding basics in clinical cardiology. We have created a group. We have created a group with all you, the registered delegates. If there are any questions, we can be put in the group. Your certificates are probably ready in the backstage over there. And many thanks to Terumo, who provided us with the coronary stations, all our pharma supporters who are there behind us to support us in our venture here, to all my department colleagues who are sitting there in all aspects, the BD team led by Anup, who was fantastic, our managers, our food and beverages, the IT team who are sitting night and day making these things, the security guards, and everybody. If I have missed out anybody, our Salim sisters over there who are the compares. They're not sisters, but they all both have the same surname, so I call them the Salim sisters. And my biggest thank you for all you guys who came up today on a Sunday morning. Thank you very much. So yeah, so that wraps up. So you don't have to sit here anymore. You can get up now. And we have arranged lunch downstairs in the executive canteen. If anybody wants to say something, they're free to speak. Any comments, any positive or negative criticism, or any comments for our program. Otherwise, lunch is organized downstairs. You can collect your certificates from here and proceed down. Our staff will be there to help you, assist you, and see you all next year. Ta-da, bye-bye. Thank you.
Thank you once again. Thanks to all our speakers, faculty, and delegates. That brings us to the end of this year's program. We hope you enjoyed the sessions, quizzes, and hands-on activities and found them useful. This is Alma Salim
and Lean signing off. Thank you all for being a part of CME Back to Basics. See you next year for season 9.
Thank you.
Yeah, if... Hello. They will not be... Yeah. Yeah, if anybody had anything good to say, you guys can put it up in a Google review at our Aster MIMS site about the program, about the academics involved. We'll be glad to have some positive... Our team would be glad to hear some positive reviews on Google. Thank you very much.